Good morning, everyone, and welcome to the second annual Push for Empowered Pregnancy Stillbirth Prevention Symposium. My name is Samantha Banerjee. I am the Executive Director of Push for Empowered Pregnancy. And we are just so grateful that you are all here with us today in service of saving babies' lives. You may not know that this event was our launch event last year. It was the very first thing we did. And we weren't sure if we were going to do it again, honestly, until a few weeks ago. But we received so many messages from families literally all over the world saying how much this event had helped them, how much they had learned, that, even a year later, I was still receiving emails saying, thank you for putting this up. So I just want to make sure that everyone who has been a part of making this day happen knows that you're truly making a difference. And so thank you to everyone joining us. Thank you to all of the speakers who are sharing their time and their expertise so generously at no cost. Everyone has donated their time today. And thank you to everyone who donated to help us cover the costs for the platform to run the event today. We're just so grateful to have so much support out there. So 1 year ago, almost today, I think it was the 22nd, this was our Push launch event. And our all volunteer crew has been insanely busy since then. If you would like to see what we've been up to, there is an awesome recap of just a handful of the highlights from the past year.
It all began with one mom experiencing a staggering loss. Something that she learned could have been preventable. That one mom realized this was not being talked about enough. She became a change maker, and Push was created. We quickly grew from one change maker to nearly 100 and growing. When you have that many change makers working together, things happen. A lot of things. We caught our stride with the onesie walk. 900 onesies were held walking the streets of New York City. Then, the hashtag #HeyACOG campaign. We found ourselves in meeting with ACOG leadership. We raised more than $190,000 to fund the first ever Rainbow Clinic. Wow. We even made history with the Shine for Autumn Act. And we continue on with our biggest push yet. March on Washington. 23,000 empty strollers will be pushed through DC, demanding change and empowering mothers. It's incredible what we've been able to accomplish in just 1 year, all because of our change makers. And the biggest change makers? Our children. Push is their voice. Push is their legacy. The journey is hard, but we're not backing down. We never will. We will push.
Need to take a moment to thank all of our sponsors and partner orgs, particularly Believer, who has chosen Push as their charity partner for the year and is so incredibly generously donating not only their time and expertise to helping us improve our branding and marketing, but also a large chunk of their proceeds for the year. So we are just so incredibly grateful for all of your support. They actually created that beautiful video as a surprise for our first anniversary. I also want to give a huge shout out to all of our partner orgs who are here today, many of whom are participating and who have just been so incredibly valuable in helping us achieve our mission over the past year. I mean, not have made nearly the progress that we have without all of the people who've come together and united with us to help get the word out about stillbirth and help empower families and providers. So before we get started, as I mentioned before, my name is Samantha Banerjee. I'm the Executive Director of Push for Empowered Pregnancy, and I am also a bereaved mom. So 8.5 years ago, I had a perfect first pregnancy. I walked into a hospital in labor after 9 months of pure bliss, so excited to finally bring home our baby girl. She was our first daughter, the first grandchild on both sides of our family, and she was so, so loved and anticipated. The doctors had called everything about my pregnancy textbook. I'd read all the books, followed all the rules, and Ilana and I were the picture of health. But I walked into the hospital that day, just 2 days before her due date, only to be blindsided with the news that her heart had inexplicably stopped beating. We delivered her lifeless body, perfect, beautiful, except for the one thing that really mattered. We kissed her dark hair and told her how much we love her. And then somehow I walked out of that hospital with empty arms, and we drove home alone, her brand new car seat rattling empty in the back. I soon learned that the most heartbreaking part about this story is that it's not at all uncommon. 65 families every single day in the United States lose a baby to stillbirth. But nobody's talking about stillbirth. No one's talking about stillbirth, and no one's giving families the chance to make sure that everything possible is done to get their baby home safe. How can families be expected to protect their children against a risk that they don't even know exists? That's simply not fair. So we are here today because we are saying enough. There are 23,000 families that lose a child to stillbirth every year, and most of them never knew that it could happen until it happened to them. They warn us about SIDS, they warn us about premature birth, they warn us about listeria, they warn us about guns and drowning and car accidents, about fire and poison and flu. Well, guess what? Stillbirth claims more children's lives every year than all of those causes I just mentioned combined. And stillbirth is just as preventable as any of them. But no one ever warned you about it until it's already too late. Research and the efforts of our international peers show that we should be able to cut this number in half if we make it a priority. Did you know that when it comes to the average rate of reduction of stillbirth, the US ranks 48th out of 49 high-income countries, and 183rd out of all low, middle, and high-income countries in the world that report stillbirth rates? That is absolutely shameful, and it is beyond time for change. The families who launched Push for Empowered Pregnancy with me 1 year ago came together to take action and ensure that no other parent goes without this empowering information that we wish we had been told. We came together to make sure that no family has to live with the devastating what ifs that we do. If only we'd known to pay attention to our baby's movements. If only we'd known that it's an old wives' tale that babies slow down at the end of pregnancy. If only we'd known to measure the placenta. If only we'd known that if our providers aren't listening to us when we say that there's a concern, that we need to fight harder to be heard. We'll never be able to prevent every stillbirth, but every family who suffers a loss deserves to know that they and their providers did everything possible to give their child the best possible chance. Infuriatingly, almost no stillbirth family can say this in America today. We have to do better because the silence surrounding stillbirth is lethal. Families deserve to know that stillbirth still happens, that it happens even in healthy, low-risk pregnancies like mine, that it happens to parents from all backgrounds, all races, though it's twice as common in women of color, and particularly Black women, because of institutionalized racism in our medical system. And every family deserves to know that it could happen to you just as it happened to all of us. And what we need other parents to understand is that we don't tell you this to scare you. We tell you because knowing gives you the power to act. Our babies who were born still count. My daughter, Ilana, still counts. And if you are one of the 1 in 170 expectant families who've been decimated by stillbirth, we want you to know that your baby still counts too, and you can make a difference. Help us call for change. We are our children's voices. Providers, you are our children's champions. Together, we can end preventable stillbirth. We just have to care enough to try. UnitedWePush, for families, for babies, for change. Thank you. And now I would love to turn it over to our morning keynote speaker, Dr. Neel Shah. Dr. Neel Shah has been called one of the 40 smartest people in healthcare and is a globally recognized expert in designing equitable, trustworthy solutions to improve healthcare systems. He currently serves as Chief Medical Officer of Maven Clinic, the world's largest virtual clinic for women's and family health, and is an assistant professor of OBGYN at Harvard Medical School. He's also a co-founder of our amazing partners at March for Moms, and he was featured in the recent Sundance winner, Aftershock. Dr. Shah is joining us today to share his expertise in how gaps in U.S. healthcare are letting healthy mothers and babies die.
Hi, everybody. Happy Saturday. I'm going to tell you a secret. It's actually Friday night, and I'm pre-recording this. But it is an honor, even in a pre-recorded way, to welcome you to the Stillbirth Prevention Symposium. I'm honored, of course, to speak today alongside so many wise clinicians and powerful advocates, and grateful for Push for Empowered Pregnancy for putting this conference together. I want to start off by just telling you a little bit about myself. So I grew up in a multi-generational household, which means I was raised by my parents as well as by my grandparents. And my parents are Indian immigrants, so they are, straight-laced and careful as a rule, as many immigrants are, and came to the United States because they wanted opportunity, economic opportunity. They came over on an H-1B visa in the late 1970s, and then they brought their parents over with them to help raise us while they had to work. My grandparents, I guess they emigrated in a way too because they came with my parents, but they were really revolutionaries. They grew up in a country that was colonized. And they were part of the effort as young people to decolonize India, to push for independence and democracy. And so in many ways, they were kind of radicals. And as a result, I was raised with both sensibilities, the carefulness of my parents, the pragmatism, as well as the perspective of my grandparents, which, gave me a healthy admiration for radical thought, I guess, as well as this appreciation for the pact that every generation should have for the next one, which is to leave things better than we found it. But we're living at a moment in the United States where there's a pervasive feeling that that's not happening. And there's actually a fair amount of data. But in terms of the feeling, whether it's Build Back Better, which is the slogan of the current administration, or Make America Great Again, which was the slogan of the last administration, both ideas are tapping into the sentiment that hope and opportunity in the United States is eroding. And the data, there's economic data, there's healthcare data, that generationally things are not necessarily getting better, even in healthcare. And the leading indicator to me is childbirth. So we all know the maternal mortality statistics. By now, I think an American today is 50% more likely to die in childbirth than her own mother. And it's not just the point in fact, it's that the best, clearest way to explain what's happening is through the lens of racism, because if you're Black, you're 3 to 4 times more likely to die, irrespective of education or income. It's the Stillbirth Symposium, so we should talk about that too. Neonatal mortality, fortunately, has gotten better over time, but disparity has not. Turns out actually the difference in stillbirth and neonatal mortality today for people who are white compared to people who are Black appears to be wider in disparity today than it was in the antebellum South under slavery. So on average, by some indicators, things are getting worse. But the primary driver across the board is that disparity is widening. So what do we do about that in the context of today's symposium, where we're going to hear from clinical thought leaders and advocates on the ground that are pushing for something better. I think the existential issue for the whole healthcare system in 2022 is trustworthiness. It's not the job of the people that the healthcare system serves to be more trusting. It is the job of the healthcare system to be more trustworthy. And I guess the main message that I want to leave at the top of this symposium, because it is a hopeful message, but what I want to convey is that I feel that the last couple of years have taught me that trustworthiness is more than a virtue. It's also an output of a system that's either working for people or not working for people. So I want to say a little bit more about that, but every system is perfectly designed to get the results that it gets. So if we have a system that results in wide inequity, that's what it's designed to do. That's why we see that. I also think it's really important to remember that a bad system will beat a good person every time. I understand that, especially these last couple of years, COVID-19 took every inequity in our society and threw it to a pressure cooker, right? And when it comes to maternal health is really a bellwether for the well-being of society. So if moms are unwell, society is unwell. And that's why every form of injustice shows up in the well-being of moms, whether it's gender inequity or racial inequity or geographic inequity or generational inequity, which is what we're talking about now. But bad systems beat good people. And so we should remember that when we think about trustworthiness, because trustworthiness is about systems as much as it's about people. To be trustworthy, I think you need three things. And I say this not as an expert, really, but really as someone who's struggled with this. I think to be trustworthy, you have to be competent. That means producing equitable outcomes. We're not doing that very well right now. There's a lot more that we can do. I hope that's part of the discussion today. But being competent isn't enough. It turns out you also have to be reliable. You have to show up for people when they expect you to. The healthcare system today is not particularly good at that. You have to be dependable. You have to be reliable. And then the last bit of this, and I guess my parting thought, is that you have to affirm people's dignity. I think the paradigm in healthcare for really most of my career has been that first do no harm, right? So the way that's been interpreted is that you have to attend to people's safety first, sometimes at the expense of people's experience, which is sometimes thought of as a sort of secondary luxury that you get to after you've made people safe. But what I feel like I've learned over the last couple of years is actually we've got that backwards. The way that you make people safe is by attending to their lived and embodied experience. And that's what we've heard over and over again in cases of maternal mortality, especially among Black women, and also in cases of stillbirth, where people express concerns about something that's happening and they're not listened to, they're not heard. And for some people more than others, particularly for Black women and for people of color. So that being said, despite the fact that maybe there's been erosion, let's say, generationally, in how dangerous the enterprise of starting a family may be, how socially isolating and economically disempowering it is for many people to start families, we are at a little bit of an inflection point right now, and I think that this symposium is evidence of that. Black Maternal Health Week. It's a thing that's being platformed by the White House. Really something, honestly, a couple years ago that was beyond my wildest imagination as something that would indicate the momentum to actually make things different. And the very fact that this conference exists, the fact that people are getting together on a Saturday to discuss these issues and think about progress gives me a lot of hope as well. So thank you so much to all of you. I hope that this is a inspiring and motivating conference for you. And I look forward to seeing all of the work that you do to make the world a better place going forward. Thank you so much.
Thank you, Dr. Shah, for sharing your expertise with us and for giving such an important and thought-provoking presentation to kick off our symposium. My name is Anna Feldberg, and I'm one of the co-directors of medical innovation at Push for Empowered Pregnancy. My daughter Charlotte was stillborn at 35 weeks on November 7th, 2019. This is her hat. This next session is dedicated to her. Our next speaker is Dr. Lauren Christiansen-Lindquist. Dr. Christiansen-Lindquist is a maternal and child health epidemiologist specializing in stillbirth. She led the first study to create a new surveillance system for stillbirth in the United States. She's beloved by her students at Emory University, where she serves as the Director of Graduate Studies in Epidemiology at the Rollins School of Public Health.
Thank you so much for that introduction. It's really an honor to be here with you all today. And I'm going to address a question that I think is often on people's minds, which is, yes, indeed, some stillbirths really are preventable. And it's time that we address that and make progress towards reducing stillbirths in the United States. To address this question, I'm also going to give you a little bit of an overview of the landscape of stillbirth in the United States so that you can understand the scope of the problem that we're talking about. And that's where we'll start. So in 2019, which is the year for which we have the most recent stillbirth data, and I'll get back to that in a little bit, there were 21,478 stillbirths reported in the United States. And sometimes it's easy for these numbers to just wash over us, but I think it's really important to stop and think about just how many babies that is and how many families' lives have been torn apart and irreparably changed forever. It's important to compare how we're doing with regard to stillbirth against some other important maternal and child health issues that we aim to address. And from 2007 to 2018, we saw a really great decrease in infant mortality of about 16%. And a lot of this was attributable to incredible strides that were made in reduction of SIDS, or sudden infant death syndrome, where we saw nearly a 39% decrease in the SIDS rate. Many of us have heard about the importance of putting babies to sleep alone and on their backs and the importance of safe sleep environments. And all of that work was really, really crucial to reducing SIDS. Unfortunately, we haven't had the same success in addressing stillbirth in the United States. During this same period, we saw less than a 4% reduction in stillbirth. Stillbirth is not distributed evenly across the population. So as you can see here, American Indian or Alaskan Native, Native Hawaiian and other Pacific Islander, and Black women have substantially higher stillbirth rates than other races and ethnicities. And I want to be clear that the cause of this is racism and not race. If we take the example of Black women here, if we were to be able to match their stillbirth rate to that of white women, an additional 3,317 Black babies would have been born alive in 2019. And indeed, Black lives do matter. And it is so important that we address this stark inequity in stillbirth rates by race and ethnicity. I think it's useful to compare how we're doing here in the United States to other countries across the world. So this is a comparison of 49 high-income countries. And on the left, we're looking at stillbirth rates from 2015. And you can see here that the US falls right in the middle of those 49 countries highlighted there in pink. On the right-hand side, we're looking to see how have these countries done in reducing stillbirth rates from 2005 to 2015. What you can see on this side is that the story is even worse, that the United States was second from the bottom in reducing stillbirth rates among all of these 49 countries. And so this is important because we can see that progress can be made and that other countries are reducing their stillbirth rates at a much greater pace than we are, and that we've got a lot of work to do. So why do I think we have some trouble at reducing and addressing stillbirth in the United States? I think it's largely attributable to two myths, although certainly there are other contributing factors as well. The first is that I think people believe that stillbirths are a rare occurrence in the United States. It's something that we think about happening long before we had medical advancements, something that might happen in other parts of the world where they don't have access to the same level of care that we do. But as we just looked at those numbers before, we see that this isn't true. And in fact, stillbirth claims more lives in the United States each year than does preterm birth, SIDS, accidents, drownings, guns, fire, and influenza combined. And we pay a lot of attention to addressing mortality among all of those things for kids ages 0 to 14 years. And yet stillbirth far outshadows all of those causes of death. The second myth, and this is an important component of this talk today, is that I think that there's this misperception that when a stillbirth happens, that it was inevitable. And in fact, that's not true. Stillbirth really can be prevented. That's right, stillbirths are preventable. A US study found that approximately 25% of stillbirths were due to preventable causes. And so if we apply this to the number of stillbirths that were reported in 2019, this corresponds to 5,369 preventable stillbirths in 2019 alone. Some researchers have compared US stillbirth rates to our international counterparts. And when we make that comparison, we see that if we could match those rates, potentially as maybe as 75% of stillbirths could be prevented in the United States. So indeed, there's a lot of work to do and a long way to go. I would be remiss to not discuss the impact of the COVID-19 pandemic as we think about preventable stillbirth in the United States. So here we are in May of 2022, and we do not yet know what the impact that the pandemic has had on stillbirth rates in the United States. What we need in order to calculate these rates is we need information about the number of stillbirths that happened, as well as the total number of births, because we need to compare those two. Well, we had that denominator information a while ago. So provisional data for 2020 live births, those were reported in May 2021, and the reports were finalized later in that year. Unfortunately, national 2020 stillbirth data still are not available. And so we can't yet compare what the stillbirth rates were in 2020 to what they were prior to the pandemic. And then certainly we can't do that yet for 2021. Why is this important? I think even without access to the data that show us what the impact has been on stillbirth rates, we can safely assume that there has been some impact. And there's a couple of reasons for this. First, we know that those who are pregnant and those who have recently been pregnant are at an increased risk of severe COVID-19 disease. And this is partly due to the fact that their immune systems have been suppressed as part of the pregnancy. The CDC also found that those who were infected with COVID-19 at the time of delivery had a 90% increased risk of stillbirth compared to those who did not have a COVID-19 infection. Well, in the US, we have really great tools available to us to address COVID-19 infection and prevent severe disease and death. And those are our mRNA vaccines. And they have found to be both safe and effective during pregnancy. They've not found to be associated with any adverse birth outcomes. And it has been shown that vaccinated pregnant people have a lower risk of stillbirth. So we know that those who have COVID-19 at delivery have an increased risk of stillbirth, and those who are vaccinated have a decreased risk of stillbirth. This is an important tool that we really should be rolling out to address the impact of COVID-19 on stillbirth. Well, what's the challenge? Preventing stillbirth in the COVID era is really hampered by what we call vaccine hesitancy, which is people have concerns about taking this vaccine. So despite strong evidence of the benefits of COVID-19 vaccination during pregnancy and wide support by the CDC and professional organizations that address pregnancy, only 22% of pregnant individuals have received one or more doses of the COVID-19 vaccine. And so this is an area where we have a lot of work to do. There's lots of recommendations and support for COVID vaccination during pregnancy. However, we haven't done enough to really talk with people who are pregnant to help them understand the benefits of vaccination, but also the very real risks, to understand that if they aren't vaccinated, it is possible that they may experience a stillbirth and then have to deliver their baby who has died. So in the end, stillbirth is indeed preventable, and we have a long road to go, but we really can and we must do better. There's a lot of opportunities here for us to make strides in preventing stillbirth in the United States. So with that, I thank you so much for your time and attention. If you have any questions, I welcome you to reach out to me on Twitter. And it's at this point that I'll go ahead and turn it back to the PUSH team. Thank you.
Thank you, Dr. Christiansen-Lindquist. For talking about the importance of preventing stillbirth and how we can do better. My name is Rachel Gold, and this is my husband, Adam Beba. I am a change maker here at PUSH.
Great. And we'd like to dedicate the next session to our son, Ari, our little lion who was born still last year at 37 and a half weeks.
Our next session will be led by Dr. Andrea Vidali. He is a world-renowned endometriosis specialist, surgeon, and miscarriage specialist, and reproductive immunologist. He earned his medical degree at age 23. He completed a postdoctoral fellowship in molecular biology at the National Cancer Institute in Italy. He did an OBGYN residency at Georgetown University and a fellowship in reproductive endocrinology at Columbia University, as well as served as a director of the Division of Reproductive Endocrinology and Infertility at St. Vincent's Medical Center in New York. He is currently the founder and CEO of Prenatal, a healthcare information company that leverages his research in the fields of IVF and miscarriage and immunology. Thank you.
Rachel, thank you for the introduction. It's a pleasure to be here, to be able to make a small contribution to this meeting. And I've been asked to talk about why aren't we making much progress in the United States in terms of actively preventing stillbirths. And first of all, I think the problem is worldwide. It's not just the United States. And it deals with the fact that doctors have accepted this idea that stillbirths are purely random events for which it's very hard to find an explanation, and they have a tendency not to be repetitive. So if it happens, you just deal with the problem, you mourn through the problem, and you move on, and everything will be okay. And this, I think, this perspective is a wrong perspective, and it's a perspective that has really not helped prevention of stillbirths. And the reason why this perspective is wrong is it deals with the fact that the reality is that although some stillbirths may derive from cord accidents, are really accidental, many other stillbirths, and a high percentage of them is not accidental. It comes from a process, a chronic process that is set at the very early phases of the pregnancy, and that because of certain risk factors that I'll be talking about in a minute, there's an evolution, and then the stillbirth happens. So although there is an acute and very dramatic phase where the actual stillbirth happens which develops in the last few days or hours, in reality, we have to acknowledge that many stillbirths happen because of chronic problems. And so patients and doctors have instead been accepted this idea that in most cases there is no explanation, that these are random events. So this unexplained concept, this acceptance of the unexplained, has in my mind been one of the biggest problems, I think, in the area of course, maternal fetal medicine and pregnancy, but also in many other areas of medicine. But in general, sort of like an acceptance of unexplained as a diagnosis, and sort of like a desire to move forward, because this is such a dramatic event, and so say, well, like, let's just move forward. We don't know the reason. Let's move on. And this, whereas instead the right attitude would be one of trying to find root causes and answers. Now, a lot of the focus has been on the pathological aspect, so looking at the placenta and looking for placenta pathology, and more often than not, the answer is that there was a placental abruption. We don't know why it happened, but that's the reason. That may be the ultimate cause, but really, I think we need to look back, much further back. And I think that's one of the reasons where you're looking at just the last few minutes, whereas you have to look at the whole story. You have to look at the whole movie from the beginning. You can't just look at the last 10 minutes of the movie. I'm using a metaphor. But, where do we need to look? Where does the attention have to be placed, in my opinion? Well, in my opinion, the attention has to be placed in a number of different areas. The first one, I think, is the area, and all these areas deal really with, in my opinion, in the area of both the endocrine and the immune system, but it goes down to inflammation, but it comes down to that. But the first part of it is endocrine disorders, and I think there's a very established correlation between the presence of endocrine disorders, whether it's diabetes or thyroid disease, and the occurrence of stillbirths, and of course also obesity, which is related to diabetes to some degree, but and other risk factors. So these are endocrine risk factors that need to be acknowledged as potentially problematic. And when you identify the risk factor, then you have to do the monitoring of the pregnancy, stay on top of that pregnancy, knowing it's high risk. So determining earlier what high risk really means. And the second part, which obviously is the one that's closest to my heart because of what I do, is the one of autoimmunity. I think that we are, immunological tolerance is definitely central to development of placental disease. And pathologically, some placental diseases have been identified, although rare. But I think that the idea that immunological tolerance has to be looked into whenever there has been a history of stillbirths, or a family history, or there's a family history of autoimmunity. This is something where we need to put a lot more attention on. And the reason why we need to put a lot more attention on it, because it may be possible in the future, and even maybe possible today, to study people and look if they have a risk factor for faulty immunological tolerance, autoimmunity. I see patients who have lost pregnancy early or late, or had late pregnancy complications, who on subsequent pregnancies ended up having the same problems, and then on the third pregnancy finally they figure out, for example, that they had antiphospholipid syndrome. And so I think that this is sort of like the main problem, like a lack of follow-up, if you will. So the ability to say, okay, this person had a stillbirth, I'm seeing this person for the first time, and as a doctor, as an obstetrician, I can't assume that stillbirth was a purely random event that was unexplained. I need to dig, as a doctor, I need to dig deep into her history. I need to dig deep into the risk factors. whether they are immunological risk factors, whether there's a family history of autoimmunity, whether there's a personal history of autoimmunity, whether there are endocrinological risk factors, a history of endocrine disorders. As a doctor, I need to look into that because I can't assume that that early loss, that early stillbirth was a random event, an unexplained event. This is what I think the biggest problem. And, I'm sorry I'm repeating myself, but I think it is very important for people to understand that, because when you do go to the doctor after having your loss, and unfortunately, one of the difficulty is having to relive the trauma, because every time you tell the story, you're living the trauma again. And I think that that is hard. It's hard for the patient. It's hard for the person to relive their trauma, to tell their story. And sometimes it's easier to just mention it and kind of like not talk about it because of the pain that goes with it. But and the doctor maybe doesn't even want to talk about it, and because he doesn't want to bring the trauma back. But the reality is that it's the responsibility of the doctor also to go back, look into the history, identify the risk factors, and then identify that pregnancy as a high-risk pregnancy with more intense monitoring, aggressive management of birth, that all of which are actions that would prevent certainly a recurrent loss. But then we have to bring it even forward and say, all right, but then perhaps we should screen everybody at the beginning in those early pregnancy visits, even for the first pregnancy. Look for those risk factors, not just assume, oh, this person doesn't look sick. This person doesn't look sick, and so I'm not going to manage this person aggressively. So I think that these are sort of the obstacles to implementing a proper aggressive management of stillbirth prevention. And it's possible, it's doable. I think that what is upsetting to me is that asking the right questions ultimately may end up in getting the answers that then lead to identifying people at risk. And I think that as advocates and as physicians, our job is actually to inform other people through social media, like we're doing today. Inform doctors as patients and say, look, I've read this and this is what my issues are, and not be afraid to be knowledgeable. And so those are, I think, the direction that we have to go. But luckily, because of the power of crowdsourced knowledge, progress is being made. And so I am optimistic, actually. I think progress is being made. And this is some of the work that also we are doing. We're looking at obviously we are looking at mostly the immunological component of it, and with the prevention of pregnancy loss and recurrent pregnancy loss. But whatever we're doing also applies to later pregnancy complications. So I'm really excited to be here and to be part of this meeting of the minds today. And I'm looking forward to hearing more from some of our colleagues and other advocates and participants at this conference today. Thank you.
Thank you so much, Dr. Vidali, for joining forces with us to end preventable stillbirth. It means so much to all of us to know that there are people like you in this world questioning why stillbirth rates are still so high in the year 2022, and doing your utmost to keep other families from experiencing this heartbreaking outcome. My name is Angelica Kovac. I'm a change maker with PUSH, and I'd like to dedicate this next session to my son, Ezra Wild, who was born still in 2020 at 33 weeks and 5 days gestation due to an umbilical cord accident. When he died, we weren't sure why, not until we were so very fortunate to meet our next speaker. Dr. Harvey Kliman is an MD, PhD physician scientist who specializes in studying and treating infertility and pregnancy complications, including recurrent pregnancy loss. He is the director of the Reproductive and Placental Research Unit at Yale School of Medicine and is renowned within the stillbirth community for his expertise in examining tissue samples from the placenta to understand why a loss happened and give parents confidence that the loss was not their fault. A priceless gift for which many families present here today are forever in his debt, my own included.
Angelica, first of all, I'd like to express my deepest condolences for your loss, and thank you for that really powerful introduction. So today I'm going to be talking about estimated placental volume. Saving a life as easy as 1, 2, 3. I think to understand the significance of the placenta and why it's so important in pregnancy, one has to remember that the placenta is part of the fetus. In essence, the placenta is like the root system of the tree. The tree totally depends for its life and nutrients through the roots, and so the fetus depends completely on its placenta. If we were to cut 2/3 of the root system out of this tree, this would be a serious problem for the tree. And likewise, if a fetus has a very small placenta, but remains itself very large, it is a significant mismatch, and this is a significant cause for stillbirth, as I'll show you in a second. In one of our studies where we looked at almost 300 third trimester stillbirth cases, a small placenta was the #1 cause of stillbirth, up to 36%. So clearly, a small placenta is a critical thing that we need to pay attention to in terms of stillbirth. Obviously, there are other causes as I list here, but a small placenta is the #1 cause. I'd like to make this more tangible and real for you and present a typical, sadly, very typical case, which I'm going to say is Jane Doe here. Jane was 34 years old at the time of this 4th pregnancy. It was her 4th pregnancy. She had 3 previous deliveries, 3 normal living children. Everything was uneventful in those previous pregnancies, and everything was uneventful in this 4th pregnancy. During her normal anatomy scan, everything was reassuring. They looked at the size of the fetus and said, everything is great. At 39 weeks and 0 days, a week before her due date, there was a dot tone, basically a handheld ultrasound, was applied to her abdomen, and the heart rate was completely normal, and she felt completely reassured at this point. However, 1 day before her due date, at 39 weeks and 6 days, she felt a decrease in fetal movement. And she hadn't experienced that before, so she wasn't really sure what to make of it. And eventually she did call her provider. She went into the hospital, and unfortunately, by that evening, when she went into the hospital, she was diagnosed with a stillbirth, which is a terrible tragedy, as we've heard from so many people so far. Now, when she delivered her son, what was remarkable to everybody is he was large. He was at the 75th percentile in terms of his weight. However, his placenta, and remember, it's his placenta, was less than the 3rd percentile. In fact, this was so small that the hospital where Jane delivered really doubted whether this was his placenta. But I want to assure you that this was really his placenta. Now, one of the ways that we can assess this misbalance between the size, the birth weight, and the size of the stillborn's placenta is to do what's called a fetal to placental weight ratio. The normal ratio is 6:1. Normally, a newborn baby is 6 times heavier than its placenta. In Jane's case, her son was 10.1 times larger. This is an extremely abnormal number. Another way of looking at it is looking at percentiles. The fetal percentile, which I just told you was at the 75th percentile, divided by the placenta percentile 3, was almost 30:1. Normal, it should be 1:1. So this is very critically abnormal, and was part of the reason that the OBs really didn't think that there was a problem. So the question is, why didn't the OB know that the placenta was so small? Clearly, they knew that the baby was a very large size, but they didn't know the placenta was so small. And the reason is that currently, in clinical practice in obstetrics and maternal fetal medicine, the focus is on the fetus. And that's great. Of course, we're all looking for a healthy baby. But my contention is that not knowing the size of the placenta is like driving a car without a gas gauge. If you don't have a gas gauge, a minute before you run out of gas, the car runs perfectly normally, then all of a sudden it stops. And that's what these stillbirth cases are like. Now, am I the only person or the first person to observe this? Absolutely not. This has been seen for many decades, actually. One of the very important studies that was published in 2012 by Jen Hutchian, a beautiful study published in Obstetrics and Gynecology, showed that if you look at what's called placental weight z-scores, and just think of these as standard deviations, 0 is the mean, -1 means 1 standard deviation less in weight, -2 is 2 standard deviations. You can see as the placenta gets smaller and smaller, the risk and probability for stillbirth increases. And what she pointed out is that this is independent of the size of the newborn baby. Stillbirths occur with normal or large size fetuses. One other example, which was published by the Stillbirth Collaborative Research Network, a very large institutional study. You can see how many authors are on this study. They showed, it concluded that the number one cause for stillbirth and preventable stillbirth is related to what they call placental insufficiency, which is another name for a small placenta. And they said that management of placental insufficiency or small placentas may have the most immediate effect on stillbirth reduction. So the practical question is, can we measure the size of the placenta? As we do, we estimate estimated fetal weight now. Now, for a long time, it's been difficult. It was difficult to measure the placenta. Here's an ultrasound at 18 weeks, a cross-section of the placenta, and people said this is a very weird shape, and so it's difficult to measure it. However, with the help of my father, who's a mathematician, and my interest in this, we developed something called estimated placental volume. It is a simple, free way of looking at the placental volume. It can be performed with very basic ultrasounds, even handheld ultrasound devices. And the equation for this can be incorporated into the ultrasound machines. And I want to show you, as the title implies, how easy this is. So again, this is a normal patient at 18 weeks. Step one is to take the tip to the tip and get the width of the placental measurement here. Here again is a cross-section of the placenta. Start at the apex at the topmost point of this curve, drop down. This is the height of the placenta. Follow the same line. This is the thickness of the placenta. Take those numbers, stick it into the equation that my father developed, and voila, you have the volume. In this case, 251 cubic centimeters. Now, how easy is this to do? Well, it is so easy that in October of 2019, when I was at a meeting, I met this young woman who was selling ultrasound machines. I asked her, do you know about EPV? She said, no. I explained what it is. She says, well, let me see how easy this is. And she happened to be 20 weeks pregnant. She lifted up her shirt, put the probe on her abdomen, and here's the picture of her baby's placenta. You can see again the width, the height, and the thickness. And I used my calculator and figured that her baby's placenta was at the 80th percentile. So what does one do? One of the questions we get often about EPV is, what do we do if the placenta is small? And I'd like to share with you a basic concept in medicine that we call risk stratification. If a test comes back abnormal, we stratify that patient to more follow-up. So in the case of a small placenta, what I'd recommend to the caregivers of these women is follow the fetal to placental weight ratio. Let's make sure that we don't get a bad ratio there. The next thing is teach these patients how to do kick counts. PUSH has alliances with two organizations I've shown here, Project Alive and Kicking and Count the Kicks. Teach these patients how to follow their babies and make sure that things aren't changing. And probably the most important message, if a woman feels that there's any significant change in their pregnancy, just go to labor and delivery triage and tell them that you're concerned. Let them look at you and don't leave until you're satisfied. So in summary, since the number one cause of stillbirth is a small placenta, tracking placental size is the simplest way to prevent stillbirths due to a small placenta. I'd like to acknowledge the people that helped me with the paper that is being reviewed now for publication, my father, who we named the EPV calculator after, and my other colleagues who developed this. And I'll just leave this slide on for a minute. More information about all this work can be found at my Yale website at klimanlabs.yale.edu. And please feel free to email me directly at harvey.kliman@yale.edu if you have any questions. Personally, if you're a physician or a patient, I'll be happy to hear from you. Thank you very much.
Hello, everyone. Thank you so much for joining us today, and thank you for Dr. Kliman's speech, as well as the previous presenter here, Angelica. I had no cause of death for my son, Owen, until I also was introduced to Dr. Kliman. So it's quite emotional every time I hear you speak, Dr. Kliman. I thank you so much. It's things like this that really help families like myself, because we carried a lot of guilt after the loss, not finding out what exactly happened to our son, and as a mother especially. So I thank you very much. And I'm actually here with my own bear. He is actually the size and length of my son, Owen, who I dedicate the next presentation to. Our next presenter here is Dr. Ilan Timor. He's a professor of OBGYN at NYU Langone School of Medicine and has published 10 books on obstetric and gynecologic ultrasound. Dr. Timor also sits on multiple Society for Maternal Fetal Medicine task forces and is working with the American Institute of Ultrasound and Medicine to develop ultrasound recommendations to improve counsel on various fetal and maternal disorders. In short, he definitely knows his way around an umbilical cord, and we're so grateful that he's here to share his expertise with us today. For me especially, because my son died from cord compression. And one of the things as parents, we don't like to hear that not more could be done. And for some, that might be reassuring. But for me, it was just a constant feeling of pain to carry that feeling that more children would die from the same cause as mine, and that we're not doing more to prevent that. So thank you so much, doctor, for what you're doing.
I am extremely pleased that you asked me to present a talk about the ultrasound to identify the umbilical cord. And I am absolutely sure that it will give you a little bit of insight of what we are doing so far, what we should do, and what can be done. So at this point, everybody of you definitely know that the umbilical cord is the lifeline between the mother and the fetus. Now, what do we do today? When we scan pregnancy, we usually check the cord at its two ends, at the placental end and the abdominal end by the umbilicus that you can see in that oval that I put on the two ends of the cord, the one on the placenta on the left, the other one into the entrance of the umbilical cord in the abdominal wall. The question is this sufficient to get information about the cord, the blood flow through it, and about fetal health? And I'm giving you the answer indirectly, because I really honestly think that maybe not. So when do we do this? And one is between 12 weeks and 0 days, and 13 weeks, which we say this is the first trimester of pregnancy. And this is a relatively new guideline that was posted in 2020 by the American Institute of Ultrasound in Medicine. And I provided quite a lot of information for this guideline. In this guideline, we said that the following should be imaged: the cord insertion into the abdominal wall, as you see on the two pictures on the right, and then the cord insertion into the placenta. And again, I just repeat myself here. Now, the second time that we should image the cord, and this is by a 2019 publication by the AIUM, and it was published in the Journal of Ultrasound Medicine. And it is a detailed second and third trimester diagnostic obstetric ultrasound examination. And again, we should do the cord side into the fetal abdomen and the cord vessel number. And you can see the little picture on the right that the two vessels embrace the fetal bladder. And that's the way that we usually take a look at it. And then the placental location and the relationship to the internal os. And then also we look at the placental cord insertion. Now, what is not in the guidelines? The guidelines basically don't talk about all the possibilities that you can do. You can scan in this in these two kinds of scans. And here is a list of some of the pathologies that can be seen. I will not detail them at this very moment because I will enter each of them separately. Now, this is an excellent article that we are led by, published in 2018 by Junichi Hasegawa, Japanese, very astute worker. And he, in his abstract, says that with the improvement of prenatal diagnosis, stillbirth due to fetal anomaly decreased. However, stillbirth associated with umbilical cord factors increased. And he also says that prenatal detection of cord abnormalities based on ultrasound diagnosis will improve perinatal morbidity and mortality rates. And I concur with his statement. Here are some of the umbilical cord pathologies and their effects on the fetus. And the first one is the velamentous cord insertion. And in this case, the umbilical vessel enters the placental margin, and it does it parallel to the uterine wall, as you can see it on the color Doppler picture on the upper right, marked by an arrow, and it connects then to the superficial placental vessels that is on the lower part, and the placenta is marked by a letter P. And on the other side, on the left side, you can see how the cord is really parallels the wall marked by the two arrows there. And then you can see a picture of this velamentous cord insertion. Velament means veil, and you look at the picture on the lower part, that's a color picture of the placenta, you see that the cord is running in that membrane and approaches the placenta. Thereafter, the cord is immobile even when the uterus is shaken, and if it is not overlying the cervix, it has very little effect on the fetus. And then I say, did I say overlying the internal os? Yes, I did say that. And you can see here a different kind of forelying vessel. This time it courses through the cervix, and you can see the color picture and the grayscale picture, the upper two ones, and then a placenta that is a placenta that was delivered and shows exactly where it is. Now, this is extremely important because if it overlies the internal os, it can cause painless vaginal bleeding, especially in late gestation, and fetal deaths can very quickly result from exsanguination. So if anybody has a painless vaginal bleeding, don't think twice, go to the emergency room or to your doctor, your obstetrician, to see what's the reason for it. Now, I also say that when I work in the laboratory, I usually make it very simple to detect this kind of vessels because I use 3D imaging. And on the 3D imaging, you see the sagittal transverse and the horizontal view. And the site of the internal os is marked by the long white arrows. And you can see that each of them has in its vicinity the placenta. That is a time bomb, as a matter of fact, to make this comparison, because if the cervix starts to dilate, this is a vulnerable site for bleeding. Now, then there is a free-floating foreline cord that basically is not a problem. It only starts to be a problem when labor starts. And basically, this cord presents between the cervix and the fetus, in this case, the fetal head marked on that picture. And the management must be individualized depending on gestational age, fetal position, and labor. Next is the nuchal cord and the cord knot. Here, there is this review that I quote, including 145 studies, and it was present in 22% of the births. Multiple loops were present in 4%, and true knot rarely, but it's still 1% of the births. Now, they did not find in this work any association between stillbirth and nuchal cord, and you see that the odds ratio is very slightly over 1, which is no effect. Comparing multiple loops to single loops, it has a little bit a higher odds ratio of 2.36. We were not able to look at the effect of tight or loose nuchal loops, and I will talk about these cords in a second. The likelihood of stillbirth was higher with a true knot of cord, and you see here the odds ratio is 4.6. Now, the nuchal cord is depicted in this slide of mine that I made available for the Society of Maternal Fetal Medicine. And the criteria is that at least one 360-degree cord loop is around the neck, so a full circle. Then here we have to look at the divot sign, which you see there, the cord cut horizontally, and you see that there is an imprint into the fetal neck. And on the right side of that picture is the color Doppler. You see that the cord is looped at least twice in this case. So we have to be very attentive of this on this pathology. Now, coiling of the umbilical cord, we don't really look that well onto the coiling of the cord. The origin is unknown. It is said that the fetus is moving, turning, twisting, and therefore the cord is getting this coiling. And I think that that's a very good explanation to it. Now, also differential umbilical vascular growth rate, I don't think that's really the cause. High hemodynamic forces, I don't exactly would support this. I really mostly think that it's fetal movement. It could be a genetic factor. Fetuses with fixation of their bodies due to amniotic bands not only have relatively short cords, but also few or no umbilical coiling or helices. And that really tells me that maybe fetal movement is important for that. Now, how do you measure umbilical cording? And this is an article that explains it pretty nicely on this graph, and it says that you measure the distance between repeat coil points. Now, what do we need to know about normal coiling index? It is 0.17, so it's basically not even one whole turn of spiral per centimeter of umbilical cord. And then there is the abnormal one that it's too little or too more. Don't remember these numbers. Maybe we have to remember it when we scan. Now, abnormal coiling index basically is associated with adverse pregnancy outcome. It is not clear it is actually cause, but definitely it is an association. Now, this item needs further study, and it may be some way predictive of intrauterine growth restriction, and it warrants intensified fetal monitoring. In the future, I do believe that it may become an integral part of fetal assessment in high-risk pregnancies, not in every single, but in high-risk pregnancy. Now, I also have to tout my own horn a little bit because in 2010, I was part of a biomedical engineering group that we looked at the coiling geometry of the umbilical cord. And you can see here the pictures that we published in this article. And in cases with twisted cord, it seems to yield a very large values of gradients of the wall shear stress, which may place the fetus into high risk of abnormal development. Big words. The important thing is that if there is too much coiling, there is a resistance to flow, and that's all what we may want to remember. And on the right upper one, you see one loop that is measured there as the coiling index. And I got that pictures from Tom Shipp from Harvard. Here are several nice pictures of the umbilical cord coiling, and you can see that I marked them, the three left ones and the lower right one together with the placenta. And in the middle, that picture shows hypocoiling, so you can understand what is there when the cord does not really coil normally. Basically, they can be fetal vascular malperfusion to long and hypercoiled umbilical cords, and this may show in the second trimester or the third trimester. They are increased with the risk of blood flow restriction and adverse fetal outcome. However, it is a rare cause of second trimester intrauterine fetal death, so remember that also. Here is a uncoiled umbilical cord, and again, this is associated with single umbilical arteries mostly, multiple gestation, smaller fetal size, fetal demise. And assessment of the degree of coiling in the second trimester does not really correlate well with that seen at term. And again, this is information from the same Junichi Hasegawa that I showed you before. Now, two arteries in the umbilical cord basically is an indication that there is a three vessel cord. So you have two arteries and one vein. And you see it on each side of the fetal bladder, as I indicated before. One picture is on the right showing the left umbilical artery on both sides of the fetal bladder. If only one is seen, we diagnose a two-vessel cord. Here is a single umbilical artery, several pictures, and these may be associated with structural defects, aneuploidy, and growth restriction, as you can see it on the left pictures. And then in the middle one, shown by color Doppler, you see on the side of the bladder, there is only one single vessel. Now, entanglement of the cord, that is usually a very specific diagnosis when there are twins and they are in the same amniotic sac. And you can see here a picture there. The criteria is that it is unique to monochorionic, monoamniotic gestations. And the picture shows the fixed bunch of cords of the two fetuses. And again, we should use color Doppler. And if unsure, we should repeat the scan in several days to observe unchanged position of the cord. And here are several pictures just to drive the information home. On the upper left side, on the upper two, you will see the arrow showing the placental insertion on the upper left. The lower left shows the color of the same. So you see that they insert very close to each other in the placenta. There is no membrane between the two. The upper right shows the bunch of cords in grayscale. The lower one below it shows it in color Doppler. And again, on the very right side, you see the entangled cord. and they are in these ovals very well demonstrated. True knot of the cord is hard to detect sonographically, and it is basically our task to distinguish it between false knots of cord, which is basically it mimics a cord, but it's not really a true knot of cord. And again, this is because the fetus, being very young, it slipped through a loop of cord and then it entangled itself. It basically appears when a cross-section of the umbilical cord surrounded by a circular loop, as you see it in the middle color picture above. Unusual for a knot to tighten, especially before onset of labor. So please don't get worked up by suspected diagnosis, because basically if there is no strain on that knot, it usually the blood flow is strong enough to keep the cord open and prevent lack of flow in it. Again, we may screen for umbilical cord, and again, Hasegawa has a very nice guideline here, and you can see it here, and I will go through this very slowly. If we look at the cord insertion in the lower third, we really have to consider high risk for placental cord abnormalities, including four-line cord or vasa previa, and the precise follow-up scans are needed. In the upper middle, basically, we have to do a second trimester screening as a low-risk pregnancy. Now, when we look at this number of the arteries, single umbilical artery is possible agenesis type, and again, I talked about it, and you have to do follow-up scans for fetal growth. In the second trimester, vasa previa is very important, and it is considered as a high risk, and we have to do follow-up scans of the cervix. Velamentous cord insertion, we have to see where it is and consider as high-risk delivery, because it may rupture during labor. But again, I think the moment this is known, then the labor can be extremely safe and the normal delivery. Number of arteries, again, obstructive type of single umbilical artery, consider high-risk delivery, follow-up scans for fetal growth. The coiling should be considered as high-risk delivery, and follow-up scans for fetal growth restriction. So I think that basically I went through this suggestion mostly for the professionals, the obstetricians, and those who are doing the ultrasound. And here I will also insert another kind of systematic review and its consequence, which is expressed by an algorithm. And this author's proposed pathway for potential effects of chronic and acute umbilical cord abnormalities. And on the left, you can see the chronic umbilical cord abnormalities: decreased perfusion, malperfusion, maybe thrombotic vasculopathy, fetal compromise, and potential growth restriction. The acute one can be antepartum and intrapartum. If it is antepartum, definitely you should prevent fetal demise. And if it's intrapartum, it may cause low oxygen delivery to the fetus. And in all of these cases, the neonatologists already know that the neonate has to be observed for several days to see whether there is no lasting effect on the fetus. I hope that I was able to convey some of the pathologies. Again, some may sound threatening, but I was honest about it and made sure that you understood that this does not have to happen. it can be detected, it can be prevented, and if it is the case, it can be treated in a way that will give a good outcome. Again, my conclusions here are abnormalities can be associated with an adverse perinatal outcome. Many of these can be identified. A basic understanding of the cord structure and function is vital, definitely for us professionals, to determine the context in which to interpret its possible abnormal ultrasound findings. Ultrasound screening algorithms for the umbilical cords are available. And again, I thank you for the attention you gave me and this subject, and I am willing to take calls. Any of the members of the group, they have my phone number. I am at your disposal.
I really want to thank Dr. Timor for sharing that empowering information about umbilical cord management. He pulled that together for us in a matter of days, and it's so amazing, and it's something that all of us can use to help advocate for ourselves and our babies to get the surveillance and monitoring our babies deserve in our pregnancies. My name is Erica Bailey. I'm a change maker with PUSH, and I'd like to dedicate the next session to my son, Roan, my first child, who was born still at 39 weeks on March 5th, 2020. Dr. Linda Burke, physician, maternal health advocate, and author of The Smart Mother's Guide to a Better Pregnancy, is a board-certified OBGYN with over 3 decades of clinical experience who has dedicated her entire professional career to taking care of medically underserved women. She is also a blogger, author, member of District 12 ACOG Committee on Perinatal Mortality, and mother of 2 adult sons who have been her greatest teachers.
Thank you for that very gracious introduction. And I am very honored to be here. I want to congratulate the organizers of this very important symposium and to celebrate the opening of the Mount Sinai Rainbow Clinic. My journey in terms of preventing stillbirths actually began in 1991 when I was in the last 2 months of my residency training. My team and I had taken care of a 39-year-old mom who was pregnant. She was pregnant for the first time without the benefit of IVF. And she was my hero because at the time I was in my early 30s and recently married and was attempting to conceive. So she had accomplished something that I very much wanted. We had managed her very carefully. She wasn't going to make it until 39 weeks. We knew that. And at some point we said, okay, we have to deliver her. We signed her out. We were not on call that night. We signed her out to our colleagues who were on call. And I went home. I returned to work the next morning and was informed that her daughter was born still. And I was infuriated and I was outraged because I had never witnessed a preventable stillbirth. My colleagues had messed up. And that experience remained with me, burned a passion that still lights bright very much today. So I'm going to share 2 stories with you. One is regarding a 20-something-year-old woman who was pregnant for the first time. She had no risk factors. She didn't have hypertension, no obesity. Essentially, she had a picture-perfect pregnancy. And in the 35th week, she presents to me for a routine exam. Vital signs are normal. Her measurements are good. We hear the baby's heartbeat. And as I'm wiping the jelly off of her belly, I asked the question I always ask every one of my patients. I said, okay, so everything's good. You're feeling the baby move, right? And she pauses and looks down and shakes her head no. And I said, "You're not feeling the baby move?" And she said, "No." Now, at that point, I had two options. I could have done a phenomena that's called anchoring bias, which is the cause of many misdiagnoses. And it's explained in one of the articles in the Gray Journal. Anchoring bias is where we are set on a specific idea and we ignore other differential diagnosis, we ignore data because we are fixed on this diagnosis that we have. I opted to listen to my patient's truth, even though the heart rate was normal, measurements were good. Her truth was that she did not feel her baby move. So I referred her to labor and delivery. And when she got there, they didn't like what they saw. So they up-leveled the next surveillance and did a biophysical profile, which incorporates an ultrasound. And based on the biophysical profile, they decided that they were going to proceed with a C-section. And when they entered the uterine cavity, they discovered that not only did her daughter have a cord wrapped around her neck, but the cord was wrapped around her entire body. And that is why she could not feel her baby move. She came back a week later to have her staples removed. And she shared something with me that I will never forget. She said, "Dr. Burke, the morning that I had my appointment with you, I dreamt that my baby died. And it was so real, and I was so sad. And I had to fight back tears, as I'm doing now. I said, why didn't you tell me?" And she just shook her head and shrugged her shoulders. I share that with you because your instincts, your maternal instincts, are your North Star. No matter what your healthcare provider says, your instincts can save your baby's life. The next story I want to share is another patient. She was not, this was not her first pregnancy. She was 39 weeks. And she asked me if she could go on vacation. And I said, no, that's not a good idea for you to go on vacation. You're 39 weeks. And for some reason, I don't even remember why, but I ordered an ultrasound for her. And 2 days later, the report landed on my desk and it showed an amniotic fluid index of 5. So there was very little fluid around the baby. And the AFI, an AFI of 5 is the magic number. That is when we have to deliver the baby because there's no fluid. And so I called labor and delivery and I said, okay, so Miss So-and-so, did she deliver? And they checked their records and they said, no, she didn't deliver. And I said, are you sure? And they said, no, she didn't deliver here. So I called the patient and there was no answer. So I left a voicemail because I find out we have her baby. The patient calls me the next day and I said, okay, you had your baby, right? And she said, no, I'm still pregnant. And I said, well, then you need to get in here and see me right away because you have a problem. I explained what the problem was, and we need to set you up for a delivery. And she said, I can't because I'm in another state. And at that point, my heart dropped. And I said, okay, you find the nearest hospital and you go there immediately, right now, and explain to them what I just told you. tell them you have an AFI of 5. And this time, she listened to me. And the out-of-state hospital called and advised me that they had repeated her ultrasound and she had 0 fluid around the baby. And they were going to have to do a section, which they did, and everything turned out well. So the common denominator in both of these stories is that both of my patients had very scary moments that transformed into happy endings. And the 3rd trimester is also the common denominator because it diagnosed potential problems, not potential, real problems that were appropriately addressed. So in closing, my call to action to you, me, and we, that we advocate and we lift the influence of the importance of 3rd trimester ultrasounds, because they do save lives. And we also we encourage our sisters who are pregnant or who will be pregnant in the future to always keep that all-important question in the back of your head. Is my baby moving? Because if we can accomplish that goal, when we can accomplish that goal, then we can change the narrative and we can create meaningful change that will reduce stillbirths. And on that note, I thank all of you for listening.
Thank you so much, Dr. Burke. That presentation was so powerful and gave me chills because it took me back to my first pregnancy. And I remember being asked by my provider if my son was moving. And I was never asked about how my son was moving. And in hindsight, my son had slowed down over those last weeks. And I had quieted that inner voice that you were talking about, that something was wrong. And I chalked it up to anxiety. And I never told my doctor that my son was slowing down because he was still moving. Mm-hmm. So one of the questions we have for you is, what advice do you give patients, and especially first-time patients, on how to really listen to that inner voice and trust it?
Understand that you are the master of your pregnancy, that you are carrying precious cargo, and that baby, you're its lifeline. And I can, as a mother, I have two sons, and my instincts have never failed me in terms of my kids. And I'm an adoptive mom. So trust and believe in your instincts, because they're your North Star. And no one is more of an expert. Yeah, we are all we're board certified in obstetrics and gynecology, but we are not board certified in your pregnancy. You are the expert about your baby, not me. But it is my job as a physician to listen to you, to take an appropriate history, and then to make decisions that are clinically appropriate, keeping in mind your history. So I hope I answered your question.
You did, thank you. That is something that we all can relate to, and a lot of us struggled with in our pregnancies that ended in stillbirth. What should patients do if they have concerns and they are being dismissed by their provider?
Okay, so then you have to escalate. Hopefully you are aware of a maternal fetal medicine specialist. And I advocate that every pregnant mom be aware of who they are in their community and contact your your health insurer to find out who covers a potential high-risk pregnancy that you may have. If there is a disagreement between you and your provider, then I strongly encourage anyone to get a second opinion from a maternal fetal medicine specialist, because that's what they do. They specialize in high-risk pregnancies.
Do you think it's appropriate to ask our providers to document our requests as well when they aren't listening and dismissing us? Like, for example, if we were asking our provider to measure our placenta or measure the baby's placenta or measure the baby's cord, and we're being dismissed, would it be appropriate to ask for those requests to be, those refusals to be documented in our chart?
So, number one, you have to find out who is performing your ultrasound and whether they provide those services. If they don't provide those services, then again, you might want to consider consulting with a maternal fetal medicine specialist, because that's their area of expertise. That's their jam. They know how to do very highly skilled ultrasounds. It is within reason that you should be able to make that request. And even if someone says, well, it's not in the standard of care, the previous presenters has given you the studies upon which you can make reference to. And no one can dispute that because it's a published study.
Absolutely. How do you teach providers who you work with and come in contact with to get patients to trust their inner voice?
So it just depends on their level of openness. I have been an OB for 35 years. I'm not actively practicing anymore. I'm still licensed, and I definitely will be doing providing second opinions, consultations. But here's the thing. If you are not comfortable with your provider, get another one. Because if they don't respect you, they are not going to do a good job in managing your care.
Absolutely. As our executive director, Sam, says, vote with your feet. If your provider is not listening to you and you're not getting the care you deserve, go somewhere else, because they are working for you and your baby. Thank you so much.
You're welcome.
Your presentation was so powerful, and I'm so glad you brought up the piece about fetal movements, because I myself am an ambassador for Count the Kicks, which is an evidence-based stillbirth prevention campaign. And our mission is that every pregnant person knows that paying attention to their baby's movements and reporting a sign of change can save their baby's life. So thank you so much for bringing a light to that.
You're very welcome. My pleasure.
Hi, everybody. Thank you, Dr. Burke. It was amazing hearing your stories and see how empathetic you are, and to bring it up, the fetal movement as well, and how we need to advocate for ourselves. My name is Fernanda Sheridan. I'm co-director of Medical Innovation and Advancement at PUSH for Empowered Pregnancy. I would like to dedicate the next session for my son, George, and my daughter, Natalie, who were stillborn in 2017 and 2018, respectively. And now I want to present Dr. Joanne Stone, who is a maternal fetal medicine specialist focused on optimizing the care of high-risk pregnancies. And she currently serves as the president of the Society of Fetal Medicine, and also is chair of the Department of OBGYN at the Icahn School of Medicine in Mount Sinai. She's also known among the Lost Mom community, the doctor to go to in New York. And she opened the Rainbow Clinic in New York City, which is going to be great for the our community. Thank you, Dr. Stone.
Thank you so much, Fernando, for the introduction. It's such a pleasure for me and an honor, really, to be speaking at this important symposium. I'll be talking today about how the Mount Sinai Rainbow Clinic is really changing prenatal care for our patients in the area. As you are sure well aware, stillbirth affects about 1 in 160 births in the United States, which is really quite a high number. Risk factors include Black race, age of 35 and above, particularly age 40 and above, lower socioeconomic status, certain lifestyle issues like cigarette smoking, underlying maternal conditions like chronic hypertension, diabetes, and obesity, multiple gestations, and really importantly is a history of a prior stillbirth. So unfortunately, the data really shows that we haven't done too much to move the needle in this regard. When you look at data on late fetal, early neonatal, and perinatal mortality rates between 2014, 2007, and 16, and you could see 2014 is represented by the dark blue, the green is 2015, and the light blue is 2016. Whether it's perinatal, late fetal, or early neonatal mortality rates, they've really remained incredibly stable. And this really shows a pressing need to address this, and also more research that needs to be conducted in this area. This is data from the Star Legacy Foundation that highlights the importance of maternal age. And you can certainly see the rise at opposite ends from a higher rate in adolescents and teens, and then increasing starting at age 35, and really almost exponentially at age 40 and above. And in New York, it is not uncommon to have women who are 35 to 40 to 45 being pregnant and carrying a child. When you look at the data also on maternal race and ethnicity, it's really important when we think about the incredible diversity of the population in New York City. We are at Mount Sinai on the border of the Upper East Side and East Harlem, and we have a very diverse population of patients. We really do need to focus on the increase in stillbirth rate among Black patients. So I want to talk about, sort of some of the components of the Rainbow Clinic that we set up here. So again, because we know that women with a history of stillbirth have about a twofold increased risk of a stillbirth and a future pregnancy, there's really a need for specialized care that addresses finding out all about the prior pregnancy loss, including all the records, the pathology reports, what happens, speaking to the patients, and then formulating specialized care for the future pregnancy. So we know that pregnancy loss alters the reality of subsequent pregnancies in a really profound manner, and I want to thank Dr. Hiesel for the courtesy of this slide. And all the work that he's done developing the Rainbow Clinics in the UK. He's already shown you the amazing results that he's had, and this stood out to me as such a compelling reason to have this clinic here in New York City at Mount Sinai, and I really applaud the work of Dr. Hiesel and all of his team in this area. We need to meet the needs by providing additional antenatal appointments and also technological surveillance, whether that's through ultrasound, non-stress tests, things like that. The providers and staff have been adequately trained to understand the sensitive needs of the patients, and I'll go through this in a little bit more detail. And then, of course, we also provide specialty care and support by our social workers and nutritionists. So here, again, we modeled our clinic after the Rainbow Clinic in the UK. It is comprised really of care by maternal and fetal medicine specialists, psychological support and mental health services by our social workers, nutritional support by our nutritionists, again, the training of the staff, our electronic medical record, which we use Epic here, is a way that we can identify patients as being part of the Rainbow Clinic. So it appears as like high priority in the top of their problem list. We're still working on a more obvious flag other than the problem list. I'm working with the Epic team on that. We started with a half a day a week. So far, most of this has been preconceptional counseling, although patients can schedule the first OB visit if they haven't been seen by us before. And then subsequent visits are incorporated into the physician's schedules. And then we also connect patients if they want to for support. So I want to talk a little bit about the training that's been done, because I really am so grateful to Push for Empowered Pregnancy for putting together such an incredible training module. And it really was developed to give providers and staff guidance for caring for Rainbow Clinic patients. And you can see in the next slide, this is the general curriculum. You go through a whole series of different modules. I think there are around 52 modules with a welcome. And then really what is incredible was meeting the patients and listening to the patient's stories, which is just so compelling. It also is an introduction to the clinic and how the care will proceed throughout either preconception, the first trimester, and then subsequent trimesters. I will tell you that the feedback I got from the staff was how incredibly compelling this training was, and that for many of them, they were so emotional they had to stop for a bit and then come back to it a little bit later because they were so invested in what our patients have gone through. So this is from Dr. Hiesel again. The focus on how we work is preconceptional care, going over a full history, looking at pathology, and then a new OB visit, ultrasound for viability, document the plan of care, offer genetic testing or screening if patients want that, frequent ultrasounds and placental volume measurements, measuring the fetus on a regular basis, using Dopplers as appropriate. I mentioned the estimated placental volume. Awareness of fetal movement. Many of our patients are now very conscious of that, and any change in fetal movement, they know to call right away and not to wait. And then providing the psychosocial support, because all of them are just operate at such a different level of stress. And then we plan for delivery, timing, and mode of delivery, and then support around the birth and postpartum period as well. We individualize the management, and again, this goes back to the initial cause. How much of a genetic workup was done? What do we need to do? Was there a growth restriction that was present? Was the placenta normal size or small or very large? Was it related to a cord accident? Are there other maternal conditions that need to be addressed? Any lifestyle changes like smoking cessation or weight reduction? And then what are the potential therapies that we think are appropriate? And then again, very frequent monitoring the pregnancy and counseling about fetal movements. And our patients know that, if they need to come every day, that's fine. They come as much as they need to. So again, ultrasound plays a key role. These are measurements that we take, measuring the head, the abdomen, the femur to estimate the weight. We use measuring the blood flow through the umbilical cord in patients where the fetus is small. And then explain the antepartum surveillance, what a biophysical profile is. It's an ultrasound assessment of fetal well-being. This is an example of the estimated placental volume that Dr. Kliman had spoken about. And then what is really interesting to me is that the Rainbow Clinic has also attracted patients who not necessarily had a stillbirth, as we define it as being 20 weeks or later in pregnancy, that have had experienced a loss in a different way. So, for example, somebody that has had a first trimester miscarriage and has felt the devastation from that loss has come to this Rainbow Clinic. We don't really enroll them in the same way with the research and IRB that we do, but we still give them all that time and support that they need. We have I took this picture today actually. We have a screen that scrolls through all the different events that are occurring in our OB/GYN department. And I noticed this came up today. This is our advertisement for the Rainbow Clinic, and this is our phone number, 212-824-ARBO. So finally, our goal is to improve the patient experience, reduce any fear and anxiety that they feel throughout their pregnancy, add to the growing body of research that Dr. Hiesel and Dr. Kliman and the other speakers in the symposium have added to, and ultimately improve the outcomes in reducing stillbirth. So thank you so much for allowing me to talk today.
Thank you so much, Dr. Stone, for being such a champion for our babies and for all families who are experiencing the harrowing journey of pregnancy after loss. We are just so thrilled to have launched the New York City Rainbow Clinic at Mount Sinai. And we have been hearing from families all over the country who are just calling to say how much hope it gives them to know that they have this level of service available to them. If you are one of those families, please know that you can go to our website, pushpregnancy.org/Rainbow Clinic, to find more information about the Rainbow Clinic model, contact information for Dr. Stone's clinic, and also a list of other trusted providers. And for any providers watching, we want to make sure that you know that the training that the Mount Sinai team completed is available to you. It's available to anyone who is interested. Again, if you go to pushpregnancy.org and either the Rainbow Clinic page or the provider tools section, you will find a link to the online training where you can set it up. If you would like to get a code to preview it for free, please just send us an email at info@pushpregnancy.org. So we are going to take a short intermission now and plan to come back starting our next block of speakers, which is called Featured Speakers, a Deeper Dive. All right, we will see you in 5 minutes. Thank you so much.
Welcome back, everybody. This has been so incredible. So thank you so much to all the speakers who have already spoken. We have a lot of more really great content. My name is Hillary Hughes. I'm the co-director of organizational development for PUSH, along with my mom. I'd like to dedicate the next session to my son, Oliver Cohen Hughes, who was stillborn in 2013 at 34 weeks. What happened? Sorry, background's messing up poor Oliver, but he's here with us in spirit and in our hearts. I'm going to pass it along to my mom to introduce our next incredibly interesting speaker.
I'm happy to introduce you to Dr. Kristin Myers, who's an associate professor of the Department of Mechanical Engineering at Columbia University and one of the lead investigators for the IRIS Fund in collaboration with an OB/GYN at Columbia University Irving Medical Center. She received her mechanical engineering doctorate and master's from MIT and was awarded the Presidential Early Career Award for scientists and engineers for her work in understanding tissue growth and remodeling in pregnancy. Her groundbreaking research through the IRIS Fund has also been featured on the Netflix and Vox series Sex Explained. And when I had my first child close to 45 years ago, I was shocked that we didn't know why women go into labor. And apparently we still are working on that. So thank you, Dr. Myers, for being the one who will probably let us know how.
Thank you so much for that kind introduction. Thank you to the organizers. It is my privilege to be here today as a mechanical engineer, a professor, and a mom to share an engineering perspective of my study of preterm birth. So let me share my screen. I also want to thank the Iris Fund for recommending me and introducing me to this amazing symposium and the advocacy work of PUSH. The title, is We Still Don't Know Why Labor Happens, but I want to be positive, and there's good news. Scientists, doctors, patients, families like yourselves, and engineers are rising to action. So let me speak for the engineers. So today's talk, I'm going to focus on understanding the biomechanics of pregnancy and assessing the risk of preterm birth, or also just understanding what's going on in pregnancy and how could a mechanical engineer bring perspective. We heard a lot this morning on technological assessment, ultrasound, and I'm going to speak to that today. We even heard about a physician's mathematician father creating equations to understand placental volume. Can we have more mathematicians and engineers applying our skills to understand more what's going on in a partnership with patients and caregivers and physicians? So I'm preaching to the choir here. We all know the statistics of preterm birth. So just shift the focus a little bit. Preterm birth, the world that I exist in mostly, affects 10% of pregnancy and is geographically variable in the United States. So rates remain high. So looking at the map on the left from the March of Dimes, you'll see preterm rates vary across the country, where states in pink and yellow have the worst preterm birth and pregnancy outcomes. Also, as stated by Vice Presidents Harris and many others' recent call to action on maternal health, Black women, Native American, and women in rural settings experience preterm birth and maternal death far worse. Although preterm birth involves multiple and overlapping phenotypes, there are many different risks that many people are studying. Me as a mechanical engineer, we tend to focus on the mechanical etiologies such as cervical insufficiency, premature preterm rupture of the fetal membranes, preterm labor caused by perhaps uterine over distension and stretch, such as the case of twins. Preterm birth is likely caused by some of these combination of various factors, and this combination can be different for each patient. But the final common pathway is often cervical dilation, and often the cervix is a physician's window into the health of the pregnancy. So we initially started looking at the cervix. There are a few clinical interventions that can be used to prevent preterm birth. Many of these you may be familiar with, but 95% of cases still remain intractable to current therapies. Also, empirically introducing treatments to arrest something like cervical shortening or premature cervical remodeling could possibly be ineffective, harmful, and expensive if we don't have the proper risk assessment on who we can identify who is at risk and who is actually in need. And you can see some of these interventions. Some are mechanical in nature, bed rest, which is not typically prescribed by some, but oftentimes in a high-risk pregnancy, just relieve gravity on the cervix, on the uterus. There's a biomedical device called the pessary, which is a silicone donut, which is meant to squeeze the cervix shut. So the physicians have an understanding of the mechanics of pregnancy somehow. So we do know that it's important. So my vision is, can we bring engineering innovation, the whole, what engineers can do to the care of pregnant people? So a mechanical engineer, again, I often stepped into this space. It's odd. What's a mechanical engineer? You Google mechanical engineering and you see factories, car building. I'm actually from Detroit. I used to work at General Motors. I used to work in factories like this. We make and we build things, and we are really good at understanding how parts come together in an assembly and how they perform a function, whether it's fly an airplane, drive a car, etc. And I was trained this way. I was trained to understand these things. We do this sort of making and building and designing and understanding in medicine a lot. Engineers and medical providers have long had a history of biomedical devices. Here are just 3 examples. On the right here, we have a stent, what might be put into an artery to mechanically open up a clogged vein. On the lower right, we have a pacemaker that might be put into a heart. So you have an electrical engineer, you have a biomedical engineer working together again with the physician to understand how we can improve the heart function, how we can keep somebody alive. On the left here, I have a hip implant. Again, these are again, an intersection of engineering and medicine. Well, what about women's health? where are our technological innovations? What about pregnancy? There are many moving parts that are living and growing and stretching, if you will, that are critical for maternal and fetal health. Why don't we have more engineers in this space? So what is biomechanics exactly? So biomechanics is a subfield of engineering that I study. It seeks to characterize and quantify how the human body functions under mechanical loads. It's obvious in orthopedics, some of the examples I've been giving you. On the right is a three-dimensional computer model of the knee. You could see that you've got two bones coming together with soft tissues protecting our bones. On the right of that three-dimensional model is what we call a finite element analysis. It's giving us an indication of how much our load our knee experiences. So typical scientific questions we ask in this space are, how are external mechanical loads applied to the knee or our elbows or etc.? How do organs cooperate to carry this load? How do tissues respond to this loading, etc.? So this seems natural in orthopedic biomechanics. But what about pregnancy? So the fetus is supported and protected by many biologically active soft tissue structures. On the right, I actually have my own computational model to understand how the uterus grows and remodels from something that's very small to the size of our fist to the size of a full-born baby. So that's just remarkable when we think of engineering materials. So we know that the cervix, the uterus, the fetal membranes, the placenta all have really beautiful mechanical functions that I would like to know more about. And we do know that these sort of biomechanical signals that they endure trigger things like tissue remodeling, contractility, and rupture. So the mechanical integrity of these tissues are important. So I have a vision as an engineer working in partnership with physicians, technologists, etc. Can we have a better preterm risk assessment tool to alert action that can be built with a mechanics-based approach or an engineering-based approach? So given patient-specific metrics, perhaps that we can give non-invasively through ultrasound or through some new tools that engineers developed, perhaps some endoscopes that a woman can apply herself to assess, is her cervix remodeling too fast and too soon? Can we put this together with something, perhaps from a blood draw or cervical vaginal fluid from a tampon that we can collect? Can we unlock the biology of what's happening, put these together to have, to calculate or identify clinical biomarkers that are going to be a better fingerprint for the health of your pregnancy? So we have this vision, we're not there yet. We need a lot of research, biological, scientific, engineering research to make this happen. But I will say there's a whole bunch of engineers that are really excited about this and that want to make this happen. And I'll give you an example in my lab. So pregnancy biomechanics, like the introduction said, this is something that I got sparked in me as a graduate student at MIT. It took Dr. Michael House, who's a maternal fetal medicine specialist, to walk across the Charles River in Boston and knock on my advisor's door, who was a mom of two with two very eager graduate students. You can see me and my friend Anastasia. He said, hey, I'm delivering babies at 23 weeks. There's something going on mechanical. Can you help? So we launched a project to understand the mechanical properties of the cervix, and that's something that I published in my thesis in 2008. And since then, I've been at Columbia University for 11 years, working with physicians. Here I have Dr. Joy Vink on the lower right and Dr. Ron Wapner, who are our OBGYNs at Columbia University. And on the top, I have a lab full of super excited biomechanical engineers that want to work on these problems in maternal and fetal health. It's been a really beautiful collaboration. We've built some computational models. I'm going to keep going through, and we've made some great discoveries. I want to show you something really quickly. We have come up with a very sort of minimally invasive workflow. It's a partnership between industry, OBGYN, and myself. So this is what we do is we can build computer models of your pregnancy based on ultrasound scans, similar to a fetal anatomy scan. And then working with this Swiss startup company, we are also have a tool to measure cervical stiffness. And both of those measurements together, we believe or hypothesize that we can better predict if you're going to have a preterm birth or not. And so we currently use this workflow to investigate the mechanical loading environment to study the cervix. So what you're looking at here are 12 different cervices from 12 different high-risk patients. And what I'll show you these results. So what this heat map is showing you is the mechanical load on the cervix. You could see that 2 women are different from all of the rest. So we've crunched the numbers, we've measured everything, and on a patient-specific basis, these 4 women here delivered at, I think, between 34 and 37 weeks. But it's these 2 women here that were quite special. Let me get that. These 2 women here actually had particularly soft cervices. So with our measurements, again, all of these women were considered clinically high risk, but really maybe only a handful of them actually delivered preterm. So imagine all 12 of these had clinical actions that were high risk. So again, we were thinking that, again, with a mathematical equation to actually better understand the mechanical environment, can we do better at risk assessment? So I'm going to end there. We have many lessons learned. I am of the sort where any kind of discovery that we have mechanically, we've put it all online, we've open source, we're welcoming more engineers into this space. And with that, I just want to thank the organizers so much for having me. It's really quite an honor, again, as an engineer to step into this space and allow me to speak and also listen to your stories. Thank you so much.
Hi, everyone. My name's Camilla Castor, and I'm here today for all the babies who were gone too soon and couldn't be on this earth. So we have 5 opportunities today for you to win some amazing things from some amazing organizations. First, you want to be involved in the community leaderboard. That's our first contest. You can earn points on there. So whoever earns the most points can win a tumbler from LS Magical Creations. And then you can also win a sibling bereavement box from Surviving Siblings. So be engaged. You earn points as you're engaged. It does it automatically for you, and we'll keep tab at the end. After the second intermission, you'll find out who won. The second is the perfect attendance contest. You, just for being here, you also get some points. Whoever has the most will win at the end. You get a entry to the Aaliyah action box, and then you also get 10 copies of I'm Still a Big Sister, and you can choose to donate to your favorite hospital or nonprofit. Then we have our photo contest. So you can upload a photo of you or where you're at or any tips you have. The photo with the most likes will get a Aaliyah in Action self-care box. And once again, those are after the second intermission. We will announce who won. So post a picture, tell us where you're at, where you're watching from. We'd love to know. The next contest is the caption contest. So you can upload a pregnancy, a birth photo, a funny caption. It can be a photo of you, it can be of somebody else. The best combo will get a candle from Riker's Rainbow. And that will be after our final keynote speaker. We also have the Empowered Pregnancy Passport Contest. You collect 3 stamps. In order to do that, you have to go to the Empowered Pregnancy Passport. You click the passport stamp, you like the booth, and you leave a comment. You collect all 3 stamps and you'll be entered in a raffle through WUVA. It's $5 gift card to Target, and you get all the Push swag, so you can support us. We thank every single one of y'all for being here today. So comment, be engaged, enjoy our free stuff. It's great for us, great for the community. And I believe we'd like to introduce our next speaker, Dr. Wheeler. Thank you again. We're so thankful for you to be here today with us.
All right, Camilla, thank you so much for that. And thank you so much to Dr. Myers. It's fascinating to see the intersection of medicine and engineering, and thank you so much for everything you're doing. Hi, everybody. I'm Laura Forer, and I'm a change maker with Push, and I work on the email communications. I do this for my daughter, Naomi, who was stillborn in 2018 at 38 weeks. And I'm very excited to introduce Skye Wheeler, who's a senior researcher for the Women's Rights Division for Human Rights Watch, where she monitors and documents women's rights abuses during her humanitarian crises. She is currently researching the impact of extreme weather events like hurricanes, flooding, and forest fires worsened by global warming on women and girls. And she also chairs the March of Dimes Mom and Baby Action Network Environmental Justice Working Group.
Thank you very much, Laura. Yes, so I'm Skye and I work for Human Rights Watch. And for the last couple of years, I've been working with lots of wonderful partners to really look at how the climate crisis in the US impacts such as extreme heat, wildfires, smoke, disasters are having an impact on maternal health and really driving inequities between who gets to have a healthy pregnancy and a healthy newborn and who does not. So first slide, please. So these are my key messages that I wanted to communicate in this short 10 minutes. We're seeing more and more attention on how the climate crisis is driving increased deaths and illnesses, reducing human well-being. One example is extreme heat. You might think it's hurricanes or tornadoes that kill the most people in the US, but in fact, heat is a primary weather-related cause of human mortality. Just one example, the Lancet estimate that some 19,000 people over the age of 65 died in 2019 from heat-related causes. But there's a huge gap in who's really being impacted. What some people call the climate gap, what one UN human rights worker, I think, quite evocatively called the climate apartheid. So if you live in a house with AC, you get in your air-conditioned car, you go to your office with AC, you're barely touched by extreme heat. But if you're a farm worker or you work in a hot warehouse, you have different exposure to heat. You might have various pre-existing conditions because of poor healthcare, because of lower socioeconomic status. You might at the same time be exposed to other impacts such as pesticides or wildfire smoke. You might have increased levels of stress, again linked to a smaller income. If you're pregnant, you might not even be able to negotiate for a very simple pregnancy accommodation, such as a stool or additional water breaks, because these rights are very poorly protected in much of the US. So the second thing I want to sort of highlight is that pregnancy is special. Pregnant people are much more sensitive to their environment. They breathe more, our cardiovascular systems are under more pressure, the hormone picture is different for a pregnant person. The health of the environment, whether it's your environment is full of smoke or extremely hot, matters more if you're pregnant. The most studied impact on pregnancy health is heat, and we'll see later that it has specific impacts. My third point is just that we need to break down the silos between maternal health and environmental health, between reproductive justice, environmental justice. We need to start seeing that these are all profoundly interconnected. Next slide, please. So just to touch on heat, there's a lot of it already and much more is coming. Miami-Dade will jump from 41 days a year historically that feel like 100 degrees, which is dangerous, to 134 such days. And by the end of this century, we'll be hitting 166 such days if we don't cut carbon emissions. But even if we do tomorrow cut all of our greenhouse gas emissions, we're still going to see big spikes in temperatures because of all the carbon that is already in the air. So public health officials are going to have to deal with increases in temperature and the detrimental impact this has on human health. Next slide, please. This includes pregnancy health. Many studies from all over the world, especially in the US and in Europe, and some in Australia, Asia, and in the continent of Africa, show that higher than average temperatures or high extreme temperatures are linked with premature birth, low birth weight, and stillbirth. Just one very useful review study, the JAMA, the Journal of the American Medical Association, the Carr et al. Study found a significant connection or link between heat exposure with preterm birth, low birth weight, and stillbirth. They looked at 32 million births in this study on air pollution and heat, and they found a significant impact of exposure to extreme heat with preterm birth, low birth weight, and stillbirth. One study that they included by Basu in California found, for example, 11.6% increased risk of preterm birth per 5.6 degrees centigrade increase in temperature. And across all of their studies with air pollution and extreme heat, they found the subpopulations at highest risk were persons with asthma and minority groups, especially Black mothers. They did include studies on stillbirth. Sandy Ha found a higher risk for stillbirth for Black mothers, mothers who are either very young or very old, mothers with hypertensive disorders, and the uninsured. And Basu did another study as well, and she found a greater risk for Hispanic women, young mothers, and less educated mothers. Next slide, please. Pregnancy, there are much fewer studies on impacts on maternal health during the pregnancy, but we are seeing some new research. For example, a survey of studies by Burke et al. Found a connection between hot summer weather and increased risk of gestational diabetes. Health economists Kim, Lee, and Ross and Slater found prenatal exposure to extreme heat increases the risk of maternal hospitalization during pregnancy, and this effect is greater for Black than for white mothers. A 2021 study in New York State by Q et al. Found immediate and prolonged effect of extreme heat exposure on pregnancy complications, and again found stronger links in African Americans and counties with lower socioeconomic position. So what can be done about all of this? Well, we need more advocacy, we need more interventions. There's not a lot going on the Hill, but Representative Underwood did include, very importantly, a bill called the Protecting Mums and Babies Against Climate Change as part of her Momnibus package, which I'm sure many of you are aware of. So do look that up. It's a really important and a really vital bill. We definitely need something like that passed that will really get resources out of Congress and into communities. Pregnancy accommodations need to be protected at work. People in extreme heat, people working outdoors with wildfire smoke need to be able to protect their pregnancies. We need better housing, we need subsidies that support low-income families to be able to filter their air, to cool their houses, and make sure that their houses don't lose coolness, that they don't get even hotter than the outside, as is the case with some housing. We need to do a much better job of including pregnant people and the people who work with them, OBGYNs and doulas, midwives, in climate planning, disaster planning. My organization looked at 115 climate plans, heat advisories, and other documents trying to address the climate crisis from the biggest cities in the US, and we found only 2 references to pregnant people, but some 37 references to the dangers of extreme heat to pets. So that things have improved, but pregnancy is still a marginalized within the ongoing efforts to try and address extreme heat, for example. Much bigger focus on older people and people with pre-existing conditions. And we need increased knowledge and capacity to act from pregnant people and families, but also providers. Frontline birth workers need to be better resourced to be able to weave in advice on the climate crisis with their clients and patients, for example. So thank you very much. I'll leave it at that.
Skye, thank you so much for that eye-opening presentation. I am Marnie Smith, and I'm a change maker with PUSH. I would like to dedicate this next session to my son, Heath, who was stillborn at 36 and 6 in 2019. It is my pleasure to introduce our next speaker, Dr. Jessica Cohen, who is a health and behavioral economist and professor at the Harvard T.H. Chan School of Public Health. Her research evaluates the impact of maternal and child health programs and policies and explores the behavioral channels by which health policies translate into health outcomes. Dr. Cohen's work has been published widely in top economics and public health journals and has been referenced in major national and international publications. Most recently, the New York Times, USA Today, and Health Affairs. Thank you so much for being with us today, Jessica.
Thank you so much, Marnie. Let me get my screen shared here. Great. Thank you so much to Push and Sam and Marnie for inviting me to come. Marnie, your powerful writing about Heath and about the sad state of stillbirth research in the US instigated our conversations, and I feel so privileged to be part of this conversation. So thank you for inviting me. I'm going to talk today about joint work with one of our recent doctoral students here at Harvard, whose name is Caroline Geiger, and with Mark Clapp, who's a maternal fetal medicine specialist at Mass General Hospital in Boston. But of course, all comments here are my own. All right, so many of us in this meeting know that the US ranks particularly poorly in terms of maternal and newborn health outcomes compared to other high-income countries. Maternal mortality has actually been increasing recently in the United States, and perinatal mortality, which is stillbirths and early newborn deaths, has been stagnant for quite some time, as many of you have heard throughout the sessions today. Ensuring equitable access to high-quality prenatal care is at the core of our efforts to improve maternal and newborn outcomes. But some of you might be surprised to know that actually our prenatal care schedule and guidelines have changed very little in decades. So for example, the 12 to 14 visit schedule that we know now has been around for decades, as have recommendations for ultrasounds and other tests. And I'll come back to this in just a minute. So in some ways, we're doing more and more and more maternal care in this country, more visits, more tests, more scans. And all of this leads to higher costs. Some of you might not know that the average woman pays almost $5,000 out of pocket to deliver a baby in the US right now. But we know that prenatal care access and use is unequal. So some people probably get more than they need, and many people get far less than they actually need. And we don't have great insight into the targeting of prenatal care and where it's creating value. Overall, our prenatal care guidelines are based on a surprisingly weak body of evidence, like, who should be getting this scan at what time, who should be getting this visit and not this. And that has a lot to do with the fact that it's just very hard to do randomized controlled trials, which are the gold standard of evidence with pregnant women for obvious reasons, that we don't want to be experimenting with this very vulnerable and important group. And so one prenatal care guideline that's persisted for nearly 50 years is the advanced maternal age designation, which refers to women who are age 35 or older on their due date. And the reason we have this designation is because we know that risks to the mom and baby do increase with maternal age. Nearly all risks, risks of preeclampsia, other maternal morbidities, risks of preterm birth, stillbirth, and miscarriage all increase with age. And so we have this sort of clinical obstetric designation of advanced maternal age to help doctors suss out, sort of who should be getting more attention or intensive care. But of course, nothing magic happens when you turn age 35. And women who are just a little younger than 35 and women who are just a little older than 35 are not in any way, meaningfully different in terms of underlying risk. There's nothing sort of magical that happens in terms of risk at age 35. It's just that at one point in the early 70s, it was determined that age 35 was a reasonable cutoff to begin offering invasive genetic testing, and that advanced maternal age designation has since been extrapolated to to many other types of prenatal care decisions like visit schedules and ultrasounds and that kind of. So, while of course it's typically unethical and infeasible to create randomized controlled trials where we, give some women much more prenatal care than others, sometimes life gives us natural experiments, which can sort of mimic randomized controlled trials in certain circumstances. And the arbitrary sort of age 35 cutoff gives us this sort of unique natural experiment to look at whether or not moms and babies benefit from additional prenatal care. And the idea here is that within a narrow range around age 35, again, like I said, patients are unlikely to be very different. So, your underlying risk of stillbirth or preeclampsia are not very different if you're just a few months below 35 or above 35. But what is very different is that once you hit age 35, you're much more likely to get this lovely complimentary label in your chart, which is that you are elderly, prima gravida or multigravida. And so this offers us a sort of natural experiment to say, okay, well, women who are just a little bit, a few months older than age 35 are designated advanced maternal age, and women who are just a bit below it are not. Can we look at differences in their prenatal care and then differences in their outcomes? So that was the sort of basis for the study that we did, and we used a large data set with commercial insurance claims. And we had around 50,000 pregnancy episodes for people who were within 4 months on either side of age 35. So what did we find? We first looked at the probability of getting a detailed ultrasound or the anatomy scan, and so the way to look at this graph is that 0 means these are women who are just 35 on their due date. And to the left of that on your screen are women who are 34 and 8 months up to 35 on their expected due date. And women above 0 here are just 35 up to 35 plus 4 months. What you can see is that about 40% of women, a little bit more, get a detailed an anatomy scan, and that increases a little bit with age. But you see this large abrupt jump in the probability of getting a detailed ultrasound right at age 35. You see a similar abrupt jump in visits with maternal fetal medicine specialists. So again, this is increasing, of course, with maternal age, but you see this big abrupt jump in the probability of having a visit with a maternal fetal medicine specialist. Turning to antepartum surveillance, this is non-stress tests and biophysical profiles. Again, you see this abrupt jump in the likelihood of getting this antepartum fetal surveillance. Which is, of course, a primary goal of which is to identify fetuses that are at risk of demise. And all of these increases, and this in particular, are particularly interesting because there's nowhere in clinical guidelines that say you should do these tests on the basis of advanced maternal age alone, right? So it's not that women who are over 35 are supposed to get this test and women who are younger are not. It's just meant to be a factor in decision making. But you can see that clearly it's an important factor. And actually, in the study, we also look at a subgroup of women who have sort of low risk pregnancies. So that means they don't have hypertension or diabetes, sort of other reasons to be watched more carefully. And these abrupt jumps at the advanced maternal age cutoff are even more pronounced, right? Because they didn't have sort of other reasons to be attended to more carefully. I'm just showing you a subset of outcomes, and there's a link to the paper so you can look at more. But I'll jump now to what you're probably most interested in, which is what happened to stillbirths and early newborn deaths. So if you look on the left here, this is all pregnancies, and just under 1% of pregnancies ended in a stillbirth or an early newborn death within 7 days. And you can see that there's a marked abrupt decrease in the probability of perinatal deaths just as you cross the age 35 cutoff. When we look just among low-risk pregnancies, you can see that, of course, the likelihood of perinatal death is much lower. It's just around half what it is for the larger sample. And crossing this age 35 cutoff nearly entirely eliminates perinatal deaths, right? So in other words, women who are just a bit older than age 35 have 86% lower perinatal deaths than women who are just a bit below it. So there are some really clear things from this paper and some really unclear things from this paper. The things that come out really clearly, of course, is that this age 35 advanced maternal age guideline clearly affects care. It's also very clear that the extra care and attention that women who are advanced maternal age are getting is strongly associated with perinatal survival. And, you know, as has been mentioned many times today, this is clear evidence that stillbirths are not unavoidable. Clearly, a substantial share of these deaths are avertable because women who are, you know, just a few months apart are not likely to be very different from one another. What's less clear, and it was really unsatisfying to me, is that we can't really say from this study which aspects of care matter most. As you can see, lots of things are different for women who are advanced maternal age than for women who are a little younger. They're getting more visits, more scans, more of a lot of things. And perhaps even more important, there are many things that our data don't speak to. So some of the things that Dr. Linda was talking about, you know, who is listened to more, right? Who, when they call with a question about fetal movement, is brought in for testing, and who isn't, who's watched more closely and who isn't. We don't have data to look at whether that's what's changing at age 35. These are the limits of using claims data. And the other thing we can't really speak to are any negative effects of this additional care at age 35. We do look at C-sections and we don't see any abrupt changes there, but this data is not great to look at a range of other potentially harmful things. So the results from this study, which came out in December, led me to PUSH and to your community. I found it incredibly unsatisfying that we couldn't figure out what was leading to these benefits for women who are just over 35. And as a curious and tenacious person working in maternal and child health, and as a mom, I want to understand what is working to save all those babies. And so, you know, and how we can use these insights to reduce avertable perinatal deaths. In particular, I'm beginning to study how U.S. health policies and programs are facilitating or creating barriers to needed care to avert stillbirths. And I'm in the early stages of creating a stillbirth prevention lab here at Harvard-Chan, together with PUSH, that's really being designed to address these questions. And we're really in the open stages of soliciting priority areas for research. And I would love to hear your input. Here's my email and Twitter. And here's Caroline and Mark, who are co-authors on the study. So thank you so much again for inviting me.
Thank you so much, Jessica. That was absolutely fascinating and so eye-opening. And I'm so excited to see where your research goes next and what information we can uncover to help us end preventable stillbirth. So I think it's really clear that there's more that we could be doing, that there are levers we could be pulling, and we're just not. So thank you so much for your dedication to saving babies' lives, to empowering expectant families and their providers, and for all you do to sort through this like incredible amount of data and make it clear. So cool. All right, well, thank you all so much. Please join us at our first panel session, which is the Stillbirth Survivors panel themed "What I Wish I Had Known."
Welcome, community. Thank you so much for joining us. staying with us as we are imparting such knowledge on stillbirth. We hope that you have received tons of information that have been helpful for not only for you, but your family as well. My name is Marjorie Vale. I am co-director of awareness with my partner, Anna Vick, and I get to be the moderator today with some amazing people who are going to impart with us what they wish they had known prior to their loss or prior to starting their organizations. I would like to dedicate this section to our son, Alexei London Vale, who was born still he would be an adult this year. He would have been 18 years old. We lost him during labor due to velamentous cord insertion. I was so grateful that Dr. Timor spoke about that earlier today. So, of course, hindsight, you always think about what you wish you could have done, what you wish you could have asked, all of these things as lost parents, the guilt that we feel that are running through our minds because we're just like, we think we could have prevented it. So this panel is going to share with us those thoughts and how they are going to empower families moving forward on how they can prevent stillbirth or anything catastrophic in their pregnancy moving forward, because our goal is 2030 to reduce stillbirth, right? So I'm going to ask that everyone introduce themselves. I want you to introduce yourself. I want you to tell us about your organization and just really briefly about your loss story and how you got involved in your organization. So I'm going to start with, because I know it gets all like weird, like who's starting, who's speaking. So I'm going to help you all out today. I'm going to start with Anne, Dr. Anne O'Neill. Dr. Anne O'Neill, go ahead.
Sure, I'm happy to go first. Thank you, Marjorie, and thank you, Sam and Push, for organizing all of this. It's an honor to be here. My name is Anne O'Neill, and my son Elijah was stillborn on his due date back in 2018. Perfectly normal, healthy pregnancy. He is our fourth child, and I just was delighted to be welcoming him into our family. We expected, just a living baby, and we were shocked to find out when we went to the hospital that he had no heartbeat. I was induced, and we eventually were searching for answers for quite a while, and eventually connected with Dr. Harvey Kliman at Yale, who confirmed that Elijah died because of an extremely small placenta that was a mismatch for his body size. Elijah was a very large baby, and his placenta was very small, and he basically outgrew his placenta. So naturally, as a mother whose baby has just died is asking, what could have been done to prevent this? What efforts are underway? And Dr. Kliman shared with us that you can, in fact, measure a baby's placenta volume in utero before a stillbirth and not just wait until an autopsy afterwards. So that really lit a fire under me to say, we need this measurement, this placenta volume measurement in prenatal care as a routine part of monitoring to help risk stratify which babies need more monitoring and which don't. At his due date, I could have been induced earlier, of course. So I've been part of a team of lost moms, and we've started Measure the Placenta. You can go to measuretheplacenta.org, and we have one goal, and that is to get placenta volume measurements as a standard part of prenatal care to detect at-risk fetuses. So that's a little bit about me.
Thank you, Dr. O'Neill. I'm going to move on to, I hope I say this right, Kaylee.
Hi, it's Kaylee.
Kaylee, I'm so sorry.
It's Kaylee. It's okay. It's complicated.
It's a teacher in me. I'm so sorry.
No, that's okay.
Go ahead.
Okay. So my name is Kaylee. I have an awareness Instagram called Every Mama's Heart. I started learning how to draw and hand letter shortly after my daughter Ella was stillborn in 2019. It was kind of a way to channel my grief. So Ella was stillborn at 37 weeks, about a week before her due date in 2019. We had a pretty normal pregnancy up until that point. I was very confident going into her pregnancy because I had already given birth to a live son in 2015. I carried him full term, and we made it to 37 weeks with Ella's pregnancy. And one day I realized I hadn't felt very much movement. So we went in to the hospital and they found that she did not have a heartbeat. And I delivered her via C-section the next day because I was in such shock. I didn't think I could give birth to her vaginally. And then we decided to try for another baby in 2020, and I got pregnant with our son, Austin. I carried him until 19 weeks when I woke up one morning and I had fluid in my underwear, and we rushed to labor and delivery. And they found that I was 3 centimeters dilated and my water hadn't fully broken, but my membranes were leaking. So because I didn't have an infection, I was put on bed rest, and I was on bed rest with him for 8 days before finally I had a cord prolapse and I had to deliver him, and he was also stillborn at 21 weeks. So that is just a little bit about our story.
Wow, Kaylee, wow. I'm so sorry, that's a lot.
Yeah.
Wow. We're gonna move forward with we're gonna move forward with Donna Russell.
Hi, everybody, and thanks. I want to thank you for putting this together and inviting me to speak. My story is a little different. I did not have a stillbirth. My son survived, but I, like everybody else here and what we're hearing today, was just totally blindsided. I was working as a senior policy advisor for the State Board of Health. I was aware of all these things. We were doing newborn screenings, all sorts of things. And when my fourth son was born, he did not seem okay to me. And I was asking and pushing and trying to get, I knew something was wrong. I couldn't get anybody to listen to me. They sent him home and he ended up crashing and almost dying from a group B strep infection. And I remember my husband and I being brought into the room and telling us that he was about to die and to prepare ourselves. He didn't, thankfully, but the policy person in me, they asked me, did you get screened for group B strep? And all I heard was, this was preventable. And it really, I will say, it just shifted me in that, we got him through and he thankfully survived. He has long-term, challenges from it, but it just shifted me into maternal health. And I went from thinking, like most of us, that we're just going to have this healthy pregnancy. We read the books, everything, we check everything off, and we expect to leave the hospital with a healthy baby. And all of a sudden, the reality hits, and you start learning. You get this awareness, and you start Googling and finding out group B strep is the leading, cause of neonatal mortality. And how did I never hear about this? And so it really shifted me, and I became a parent advocate for this. I found other parents, and we formed. Our president is going to be here of Group B Strep International. She lost her baby. So we have worked at a very, very aggressively to raise awareness, to support parents, but unfortunately they still come to us after it happens, right? So we also work proactively to try to change guidelines, and we did. My son was 22 years ago, so I was able to work to help change the guidelines. The other thing it did briefly is it shifted what I do for a living, and I started a company. I actually started within a hospital, but setting up the first open source biobank to study pregnancy, to give researchers specimens, blood, urine, placental tissue, all of that to start studying and accelerating. And more recently, I set up a company where I'm actually working directly with biotech and pharma to bring studies to community hospitals where most women stay for their care. So I feel like I only have so much time in my career. I'm going to push as hard as I can to accelerate this and get more research out there. And anyway, so that's kind of my story.
Thank you, Donna, for sharing. I do want to share with everyone, you will have a time and a space later on to be able to share how your organization can help people. So I don't want you to feel like you have to do it right now. So we're going to move on to Erica Bailey.
My name is Erica Bailey, and my first pregnancy, my son, Leon, was stillborn at 39 weeks. And in the final weeks of his pregnancy, in hindsight, I noticed that my son was slowing down. But because I was not educated on fetal movements, I never spoke up. I never told my provider. I had silenced my intuition that something was wrong, and my son died. And after he died, when I was searching stillbirth, I found Count the Kicks, which is an evidence-based stillbirth prevention campaign that I am now a part of, and I am an ambassador for the state of Missouri, because every pregnant person should be educated on fetal movement and be empowered to speak up when they notice a change. And we did find out that the reason my son died was because of a small undetected placenta. So I'm also involved with Measure the Placenta, but today I'm representing Count the Kicks. And luckily I found out about it before my second pregnancy and was able to save my second son when he slowed down at 36 weeks. We were admitted for reduced fetal movement, and because I spoke up, they listened, and my son was born early at 36 weeks in one day. And he's alive today because I was empowered with this information.
Thank you so much for sharing, Erica. You're right. Many mothers don't feel like we can speak up. We forget that the doctors are working for us and we're not working for them. So that's very important for us to know and to remember, to impart to the community that you have a voice, right? The doctors need to be helping you help safely deliver your child. So thank you for that. We're going to move on to Kalia.
Hi, thank you, everyone. Thank you, Push, for putting on this great event. Everyone, my name is Kalia Fleming, and I'm the Executive Director of the National CMV Foundation. The foundation was originally incorporated in 2014, and it was set out initially to raise awareness about congenital cytomegalovirus amongst women of childbearing age. So congenital cytomegalovirus, and you'll hear me mention it throughout the panel as CMV, it is the most common viral infection and the leading cause of non-genetic hearing loss of infants born in the US. It can also be linked to a slew of serious health complications for about 1 in 5 CMV impacted children, cerebral palsy, seizures, intracranial calcifications, et cetera, and is linked to stillbirth. And so our mission at the National CMV Foundation, which was recently updated and expanded, really focuses on preventing pregnancy loss, childhood death, and disability due to congenital CMV. So I'm representing from 2 angles today, from the National CMV Foundation, but also as a stillbirth advocate for women to get more education around stillbirth and healing in that space. I personally have not experienced stillbirth as a mother myself. However, 10 years ago, I was in the delivery room with my best friend, and she gave birth to a beautiful baby girl born still, first delivery. I was in the same situation 5 years ago with another friend who delivered a beautiful baby boy born still. And so this work is really personal to me, and really excited to be here today to share some additional resources and information with everyone.
I'm glad you shared those stories, Kalia, because I think often, people feel like they need to perk up and listen only if it's something that pertained to them or happened to them, but you're really listening for your cousin and your friends and, a family member, because you just never know who is going to need you. Similar story, I was the first in my family to have a stillbirth. A few years down the line, I had a cousin. And so, we related on that level, but we cannot wait until it happens to us to be involved. We have to be involved now. So thank you for sharing that. We're going to move on to Tamika James Isaac.
Good afternoon, everyone. I am Tamika James Isaac. I am the Executive Director of Jace's Journey. Jace's Journey is a nonprofit me and my husband started after the loss of our son, Jace, in 2018. Actually, 4 years ago last Sunday. What I wish I knew that the color of my skin could be a factor in the outcome of my pregnancy. And that is why we started Jace's Journey, to bring awareness to the disparities for equitable treatment in prenatal care, because there's just so much bias in healthcare right now. We just want people to be aware, know how to advocate for themselves with their doctors, like you guys mentioned earlier. And I'm just glad to be here. So thank you guys for having me.
Thank you so much. And we look forward to unpacking more of what we wish we knew, right? Because that's the thing. You don't know what you don't know, right? So I'm looking forward to this panel imparting to the community, like what questions or things to be looking for, not only for their own pregnancy, but for their family and their friends. So we're going to move on to Kay Matthews.
Hi, everybody. Kay Matthews. I delivered my daughter stillborn. Actually, her birthday is next Sunday. So it was one of those things that, one, you're not prepared for. You don't know what to do, how to do. And what makes it even more difficult is not only do you not know what to do, other folks around you don't know what to do. So it really makes the struggle very difficult. And that's just what I experienced. And then on top of that, for me, experiencing postpartum depression and infant loss not being linked to it. It was like foreign language to talk about anything maternal mental health in my case. And so I just struggled for an immensely long time that I felt was so unnecessary. And one of the things that Tamika just said that resonates with me is it wasn't until I gave birth that I realized the color of my skin and being a Black woman had a tremendous effect on my treatment, my care, both during and after. And definitely what I wish that I knew is that my voice actually may have changed some things, but it wasn't activated. I wasn't in an environment where I felt like folks would listen to me anyway. So I somewhat kept silent, but I'm no longer like that. But back then, my silence, I wish I had the courage and also the energy that I have now to fight and make this all better then. And I just, I pull from then now, which is why my voice is so loud about this could all definitely be different.
Thank you, Kay. We're going to move to our last panelist, never least, of course, Alexia Harrod.
Hello, everybody. Can you hear me okay? Okay, good. I just want to say I am in awe of all of you on this panel, and I am just grateful to be a part of this panel as well. My name is Alexia Harrod. I am the Vice President of Melanated Moms. And while I have not suffered a stillbirth, I have suffered loss. And I'm here representing the moms of the Melanated Moms community who have suffered a stillbirth, and for many of my friends and family that have. So I'm here to support and here to be helpful. And I'm trying to not cry, but I noticed that what Ms. Kay said, that, her voice, she didn't think before her voice mattered, but everybody's voice here matters. And what you say can definitely change the outcome of not only your life, but the lives of others. So I am extremely happy to be here. And I always say we turn meows into roars over here at Melanated Moms. So thank you.
Thank you so much. As some of you have already shared, the first question for the panel is, in your journey, your personal journey through pregnancy or watching a friend, what did you wish you knew prior to you starting your organization or being part of an organization that is advocating for stillbirth? I'll start. I know for me, I wish I knew that I could have a plan in terms of, because I gave birth in a birthing center that was in a hospital, but I never thought about emergency. I didn't think about like, okay, if there's an emergency, what's step 2, step 3? Because I felt like my situation became an emergency, it almost felt like the midwife didn't know what to do. So the doctor's coming down, we're going up. the doctor's going up. So I wish I knew, like, I could sit down and converse with her and say, okay, so if something goes wrong, right? But honestly, it's a conversation she should have had with me, right? She should have said, listen, we know you're giving birth in a birthing center, stuff happens. So this is plan A, plan B, or plan C, whatever. So that's what I wish I would have known. What was it for you? And anyone can jump in.
So this is Tamika, and I kind of spoke to this a little bit ago, but a little backstory. I contracted HELLP syndrome. So that's kind of like preeclampsia, but very critical. I had no idea what it was, right? So I had no idea what I was signing up for. I was told that I was high risk for preeclampsia because when I got pregnant, I was 40. And to find out later that they weren't even testing me for all the things of preeclampsia, and my son's death could have been prevented. And I almost lost my own life, right? So all the trauma that we went through could have been prevented by a urine sample is, you're kind of like, So that, that all of that is what I wish I knew. I wish there was more education around complications of pregnancy. I wish that in the hospital, they would have explained what HELLP syndrome was to me after they told me I had it and after they abruptly told me my son died in utero. So there's just and again, that my skin color, something I cannot control, had an outcome on my pregnancy. So that's why I, like Kay said, I now use my voice because I didn't know I needed to at that point, because my son was measuring small and they didn't act like it was a big deal. But to me, those are symptoms of something going on and they didn't look at those symptoms. So I use my voice now so people know to use theirs and I can use my voice for other people.
I really appreciate this theme of using your voice and speaking up. I know when I was pregnant with my son, Elijah, I was so concerned about being perceived by my doctors as the irrational, over-emotional pregnant woman, which is such a harmful stereotype, which comes with so many costs that are very real and very hard to document. But I was worried about this perception, and that kept me silent on things, which may have cost my son his life. I'll never know for sure, but I would just implore any person who's expecting a baby, speak up, use your voice, ask your questions. Do not worry about how you're being perceived or how other people feel about your questions. That's their problem. That's their issues if they have problems with your questions. So please just speak up and use that voice. It's really one of the best tools we have to advocate for our babies.
Yeah, I'd like to echo that with an addition to that. So I agree. We all have our gut instincts and our maternal instincts, whatever we want to call them. But I would say every woman I've talked to, including my sister who did have a stillbirth the week of my nephew's due date, we go in there and we know, and we're asking, and sometimes they just don't listen. And then you go home and in her case, the next morning he was gone. They literally told her, go home and enjoy Thanksgiving with your family. It's fine. Baby slowed down right before delivery. And she woke up bleeding and he was gone. So, and I've already told you my story, asking, I pushed so hard. My child had a fever and they told me they had an excuse for everything. So I think we know there's something inside us that's telling us something's not right, and we speak up. And at some point, because we're speaking up for ourselves, even when we do, it's easier to be shut down. So what I actually think is we need to advocate for ourselves like we advocate for others. Because if we're advocating for someone else, we are their person and we aren't going to back down. We have their back and we don't back down. And if they tell our person, no, we're going around corners or going behind their back, we're doing whatever we can. When it's us, we start to get that little bit of doubt. Like you said, we're just stressed out. We're like imagining things. We do the self-talk. So I think we actually need to advocate like we would for others. And And one other thing I wish I would have known that. I wish I would have just taken that extra bit and not gone home, not pushed to put him in the nursery. They put him on the peds floor with a fever. It was pushed when I went home with a bilirubin of 21 that he had, pushed when I went to the pediatrician next morning saying I don't like his coloring, and they sent me back home. You can't, we can push, they don't listen. So I want to echo that. I think that's what I wish, and I want to spread the word, and however we can combine our voices to really empower women, right? To not back down.
Alexia, I saw you trying to jump in. Go ahead.
Oh, I was just going to say, just really, I wish I knew to really trust my gut and really trust my body. I was in labor for 4 days and didn't know what I thought it was, just Braxton Hicks. And I ended up having to deliver my baby outside in the hospital parking lot on the ambulance gurney, because the doctor sent me home telling me that I wasn't in labor and told me that they gave me a Benadryl and told me to go home and have a glass of wine. Like, what type of medical advice is that? But I wish I knew to just trust my body, trust my voice. And if I would have done that with my middle daughter, I think the outcome would have been a little different. Things would have been a little safer for her, but I definitely learned my lesson at that point. And at that point with my third, I didn't care what anybody thought of me. At that point, I walked in I sort of rolled into the hospital with my third, and I demanded this is what I want. This is what I need, I, as a Black female, we also get, typecast as the angry Black female. And I was like, I don't care. I said, your opinion of me is none of my business, but what I am here to do is to deliver a healthy baby. And I want to be able to do that and live to tell the story. So I wish I knew to just trust myself, trust my body, and trust my voice.
And I'll echo that. So evidence of CMV infection has been found in about 15% of stillborn infants or stillbirths, and no one is talking about CMV, and they only talk about stillbirth after the fact. And so I definitely, as a woman of childbearing age, going into my regular appointments, no one's mentioning this, no one's discussing it. And talking to my friends who lost their babies, they only bring it up now because it's what I experienced the first time. So that's the first thing I wish that I would have known or been more privy to as I aged. The second thing expands what Alexia just mentioned, that self-advocacy is a spectrum, meaning we need to, yes, vocalize and verbalize, but we also need to not be afraid to shift and change completely if need be. If after talking, you feel like you're not being heard, it's time to shift. You don't have to talk all day. You don't have to hem and haw and wait. Get what you need and be okay with that. It doesn't matter about the opinions of others. It doesn't matter if I'm being perceived as the angry Black woman. It doesn't matter if, oh, here comes CMV girl. That's okay. So, make sure that when we think about self-advocacy, it's also verbalizing, vocalizing, but not being afraid to make that shift if needed.
Ladies, you are imparting such wisdom for us. And I hope that everyone is listening and absorbing what you're saying, because it can and it will save lives of mothers and lives of babies. In interest of time, we're going to move on to the next question. And I wish we could have everyone answer. But with this next question, I would love for the people who haven't spoken yet, like Callie, Erica, and Kay, to begin with answering this question. And the question is, how can your organization help, or how is your organization helping? So I'm going to start with Callie.
Hi. So what I'm doing right now is I am trying to help normalize grief after you lose a baby. And hopefully that makes it so it's more normalized to talk about baby loss as a whole. Because I feel like the stigma around it is another reason why educating pregnant women about it is so difficult. And And I would also like to shine a light on incompetent cervix. I don't know if that came across when I was introducing my story, but I had a full-term stillbirth with Ella, and then I still had incompetent cervix with Austin. So I want to encourage birthing people to ask for an ultrasound at 16 weeks to look at their cervix. I was not high risk for incompetent cervix. And it may or may not have been detected at 16 weeks. Usually it's detected at your 20-week full ultrasound. But yeah, I am hoping that with my Instagram account and with my Etsy shop, I am helping grieving people find their voices so that it's less stigmatized, so that we are able to pass along our education more easily, and we're not scaring people. We are just trying to help.
Thank you, Erica. And then Kay.
So Count the Kicks equips parents with free resources so that they can learn their baby's normal, so that they're empowered to speak up if they feel a change. And our Hallmark tool is our free app that parents can download. It works for singleton or twin pregnancies, and they just start a kick counting session, and every time they feel a kick, they just tap the foot. It's very easy. It's available in 14 different languages. We try to make that accessible to as many people as possible. We also have paper charts that can be printed off our website for people who don't have access to smartphones. And we have free resources available for providers, doulas, birth workers, anybody who comes into contact with pregnant people, available to be ordered off of our website and shipped for free if you are in a free Count the Kick state, which there's a handful of states that are, but we try to give parents as many resources and education as possible, so you have another tool in your pocket to help validate what you're saying. Even though we shouldn't need an extra tool, our voice should be enough, but sometimes this extra validation gives us the confidence to know that, yes, something is off. Babies don't slow down at the end of pregnancy. They don't run out of room. If you feel a change, speak up, go in and get checked.
That's a very, very powerful resource, Erica. Thank you for sharing that. Go ahead, Kay.
And what we do is education is a big piece. We all know that, but also how we educate is keeping it as a part of the conversation, even when it makes people feel uncomfortable. I think we worry so much about how folks are going to feel about that we tend to put it to the back burner. For me, it's not the first thing I talk about, but it's going to be somewhere in there. And that's education, awareness as well. And like I said, focusing on birthing experiences and not birthing outcomes. That's how you are inclusive. And so then it becomes the norm. We have to normalize this thing when it comes to stillbirth or loss or anything that ends in a loss. We have to normalize that grief is a part of that. And then you don't get to put a time limit on that. It's all of these educational pieces that we've talked about on this call thus far, that we have to, bundle it up and in reality, throw it at people and want them to catch it all. There's not one piece that take precedence over the next. They need all of this information because that's what awareness is. And that's also what education is.
Thank you for that, Kay. And anyone else can jump in. I would love for each person to be able to share what their organization does so that the community know who to go to if they have some certain concerns.
I'll go next. Here at Melanated Moms, we have our signature training called Find Your Roar. And we've had some people from Push for Empowered Pregnancy take the course. What we do is we provide women and birthing people that solid foundation to advocate for themselves. The course, like I said, the course is called Find Your Roar, but I always say we turn meows into roars, so that way, if you know that something is wrong, we equip you with the tools so you can advocate for yourself and you can advocate loudly to help make that change, because your voice is powerful and your words can change the trajectory of not only your lives, but the lives of those around you, and of course, your baby.
Alexia, I've heard really good things about that course from people who have taken it. So thank you for doing that. I'm hoping to do it myself. They were poking me saying, I should do that course too. So I'll pipe in quick here with Measure the Placenta. We would encourage providers to go to our website, measuretheplacenta.org, or also the Yale EPV, Estimated Placenta Volume website, and educate yourselves on how to do this really simple 30-second non-invasive measurement to get an estimate of a baby's placenta volume in utero before a stillbirth. It's quite simple. And Dr. Kliman at Yale University is more than happy to have conversations with providers if you're wondering, well, what do I do if I find a small placenta? We've thought about those things, and those are really important questions to be asking. So you can send an email to Dr. Harvey Kliman at Yale, and he's happy to converse with providers about how to do this really simple measurement. If you are a patient, we'd encourage you to go to our website. We have a 2-page informational flyer that summarizes some of the research that links small placentas with the increased risk of stillbirth, and then also estimated placenta volume measurements. So as a patient, you can take this to your provider and put this on their radar and ask, would you be willing to measure my baby's placenta size as a risk factor for stillbirth? Those are very concrete, tangible things that patients and providers can be doing to address this. Yeah, we also have a research archive on the website and many other resources. We share stories, and we also have an Instagram page at Measure the Placenta. So check out some of those resources, and we'd love to connect with you guys.
Yeah, and with the National CMV Foundation, you can visit our exhibit booth. I've uploaded a few handouts there and some resources. You can also visit the website, nationalcmv.org, to find a ton and wealth of information and resources about CMV risk reduction and preventative measures, and information how CMV is primary prevention for stillbirth as well. In addition to that, through partnering with the National CMV Foundation, we're able to connect families with appropriate state-specific CMV support and resources, connecting them with other families who've experienced this type of diagnosis, and assist families with finding providers in their state or region who are very familiar with CMV, early intervention, so on and so forth.
I'll go next. Group B Strep International, just to let you know, I think we actually have a virtual booth here and some material that is accessible. But one of the things that we've been working on for years, we understand that it can infect in utero. It can actually, what's focused right now is when that baby's born, but actually we know that it can cause stillbirth. And we finally got the data in November. There was a large-scale study partially funded by the Gates Foundation, and we now know that nearly 25% of all stillbirths are caused by Group B strep. So we are now through Group B Strep International, and I invite you all to join with us. But we're going to officially request that ACOG and CDC go back and update these guidelines, because providers listen to these guidelines, and we've been calling it prenatal onset. We really want them to recognize they've mentioned it, but never talked about it in depth or made any recommendations. So it's simple. They can just like looking for preeclampsia, they can begin to look in urine samples for colonization or infection UTIs, and then they can begin to follow and protect that baby in utero. So just encourage you to come check out the site, go to the virtual booth, but we feel it could really have an impact on nearly a quarter of all stillbirths.
I think it's me, right? So I'm here for basically two organizations, Mama's Voices and Preeclampsia Foundation, and then Jace's Journey. So with Jace's Journey, our goal is to educate college students on reproductive health. We don't have the conversation early enough, and we want to make sure we are. So that's what I'm doing. As far as preeclampsia and HELLP syndrome, know the symptoms, know the signs. I didn't. That was a part of the reason why my outcome was what it was, and just promoting people knowledge. Knowledge is power. Use knowledge as power. You have to use the knowledge for the power, but just making sure that everybody knows what the symptoms are for preeclampsia. African-American women are at a higher risk for preeclampsia. So just spreading that message and keep making sure people, like we've all said here today, advocating for themselves and others when they need to.
Thank you so much, ladies, for sharing what your organization does. And I know it is going to be very helpful for the community at large that are here with us today. We have 5 minutes left, but I definitely wanted to end with this question. And I'm going to ask specifically the women of color on this panel to answer this question and to be succinct and as brief as possible. But my question is, what advice would you give to the women of color who are listening right now in terms of advocacy for themselves when they are pregnant or in situations where they need to be heard?
I think we've already said it. I think most people up here have really already said it. No one knows your body more than you do. And we need to stop arguing with folks. We're not going to keep arguing with you. If you can't do what I need for you to do for me to survive, then I don't need you. Make sure your birth team is your birth team. Make sure you have who you need in the room beside you at all times. And if you don't think you need a doula, you do. If you don't think you need support, you do. So find that support. Trust yourself, trust your mind, trust everything about you because you know more than anybody else. And advocate for you, advocate for anybody you can and you feel like you need to.
What she said, basically. I mean, that's just simply what it comes down to. We have to be more real about these conversations. And this has been a real conversation. When you have a population such as Black women that are dying or being more affected by a lot of things, we have to bring it to the forefront. It's certainly not to say that others don't matter, but the majority right now and the experiences that we have are just, we're not listened to, we're not heard. This thing goes on and on. So really, it just comes down to finding you a support system. And you know what? Sometimes your support system may not be mom, dad, sister, cousin. It may be a friend. It may be a coworker. So find someone that is going to help you advocate. We all know that childbirth is hard. One thing we don't need to be doing is trying to fight the professionals while trying to get, no, we just, it comes down to advocacy and finding someone who is going to stand with you. It's sad to say that we need partnership in so many ways while giving birth these days, but that's just where we are. So think about a support system in many different ways. So again, that you're not standing alone, and when there's questions that need to be asked, you can have reiteration of what you're saying. If something's wrong, and somebody needs to listen. So yeah.
Thank you so very much. Thank you all for being on this panel. We're so grateful for all that you sharing your stories, sharing your babies with us. We are thankful. We're closing now because time is of the essence, but your information is, I believe, in HOVA. So if anyone needs to reach you, you can go there and you can get the information of everyone on this panel. Thank you, everyone. Bye.
Hi, everyone, and welcome back. I'm so excited to introduce you to our next panel of 4 incredible providers. The PUSH team is constantly saying how we wish we had doctors like this. We wish if everyone had doctors like the ones on this panel, our stillbirth rate would not be what it is right now. These 4 are amazing. They are everything that you want in a provider. And so we have brought them on here today to help everyone try to find people like them and learn how to advocate if you don't have a doctor who's like this, because unfortunately not all of us are that lucky. So I'm gonna spotlight you guys one by one. And as I do, if you can just introduce yourself briefly, that would be amazing. So first is gonna be Dr. Heather Florescu.
Hi, I'm Heather Florescu. I am an OBGYN in private practice in Rochester, New York, and I'm currently on call with a patient getting an epidural, so we'll see how this goes. I came to PUSH via Star Legacy, kind of long story short, but basically at Star Legacy's 2019 summit, I learned about the protocols from the UK and Australia and brought them to my private practice. So we've been using for about 3 years. My passion is pregnancy after loss support and education and awareness, and I'm really excited to be here today for as long as it lasts.
Hi, thank you very much for having me. I am a OBGYN and maternal fetal medicine high-risk pregnancy specialist in Los Angeles. And I got introduced to PUSH through Dr. Harvey Kliman, and as he was teaching me about measuring the placenta. And I appreciate being here. I've been listening to all the talks today, and I've learned a lot, and I'm sad to see that there's such a sort of void in our specialty and the care that the patients are receiving and the way they're feeling. And I'm sort of sad and embarrassed, to be honest with you. So thank you for having me, and I look forward to sharing more with everyone.
Thank you so much for saying that, Dr. Rad. And again, you can see why these are our favorite doctors ever, right? How often do you hear that? Now I'm going to bring up Dr. Tracy Chevelle.
I'm Tracy Chevelle. I too am a high-risk OB in maternal fetal medicine. I was actually introduced to PUSH by a colleague, an oncologist in Albuquerque. I was introduced to one of the founders, and we connected immediately. We have lots of common causes. I was a traditional hospital-based high-risk OB for a long time, and I decided, to Dr. Rad's point, to try to figure out a different way to sort of address what's broken in our system. I actually just created a practice at the end of 2021 called Blue Moon Perinatal, and I'm helping to help women navigate when they have difficulties from an insider's perspective, how to get the appointments you need, how to ask the doctors the questions you need. I translate medical into human. And my goal is not just to have a full panel of patients and have my own clients, but I really want to scale this up and try to think of bigger ways to fill in the gaps that Dr. Rad is talking about. I think that there's a lot of momentum to figure out better ways to fill in the gaps in care and not necessarily place it all on the shoulders of the OBGYNs. So I'm super invested in helping everybody fill the gaps. And thanks so much for having me. I'm excited to be here.
Thank you so much, Tracy. And I know everyone's really interested in hearing more about the really innovative and really needed model of care that you've come up with. And now we'll bring on our last, but certainly not least speaker, Dr. Sarah Pachman-Shetty.
Thank you so much for having me. I'm very excited to be here today. I am Dr. Sarah Pachman-Shetty. I practice obstetrics and gynecology and maternal fetal medicine in New York City. I am actually sitting outside today because it's beautiful weather because of my own screaming colicky newborn. So I didn't want to subject all of the attendees to his screaming cries. So here I am. I'm very excited to be here. I was introduced to PUSH actually through my own Instagram site, just through networking with other Instagram users and followers. And I have an Instagram site that I started, I guess, sometimes when I was a fellow, because I'd have so many patients who I'd see who say, oh, you know, I realized I had to come to the hospital because I had a headache. And on TikTok, it said having a headache when you were 32 weeks pregnant was bad. And I thought, this is just abysmal that patients aren't communicating with their physicians or their providers in such a way that they don't have basic information to protect themselves and their fetuses, to prevent stillbirth and other adverse pregnancy outcomes. So I kind of made it my mission to create a platform that gave women and people who were pregnant or trying to be pregnant information that's digestible and easy to understand, to make it easy and relatable for them to have a better time getting the information they need for a healthy pregnancy. So I've done a few lives and I try to create content that is helpful and connect patients with providers that are useful and helpful for them. So that's me, and I'm very excited to be here.
on Instagram. She is at Healthy Mama Dog. You definitely want to get on there. All right. Well, thank you guys all for introducing yourself. Thank you again for taking the time today. And I guess for first question, let's start with the basics. What are some things that patients should look for in trying to identify a provider who's going to treat them as a trusted partner? What are some of the things that you do, I guess, to show your patients that, you know, you trust what they're saying and that you want to hear what they have to say about their own pregnancy?
Jump in, Sam. I think that rather than answer sort of from what I would do, I think I am going to be able to have an easy time putting myself in the position of the patient that's struggling with that because I deal with it so much. And one of the things that's really important to address is that many patients don't have the luxury of having to make a trusted relationship with their provider because their provider may be one of 10, 11, 12 in a large group, part of a multi-specialty group. And so one of the first things that I would say is that if a patient is looking for a trusted provider, they should seek out what their options are. If they know the hospital that they want to deliver at, they should take a look at the groups that deliver at that hospital. See if, you know, which doctors, which OBs are part of huge groups where there may be less ability to have a trusted relationship with someone. See if there's a smaller size group where perhaps it might be easier to have a trusted relationship. And as a side note, the mid-level providers and some of the larger practices also love being a support person. So that's just a little tip that I feel is really important. A lot of patients are very loath to see someone who's not an MD and potentially a nurse practitioner. But I've had a ton of clients who find that they have a much more trusted relationship and an easier time actually getting an appointment. But I think it's really important at the first visit to just sort of come in feeling, understanding that at the end of the day, you're not just a patient, you're a customer. And if you can put yourself in the mindset of being an educated consumer and make your goal to come in presenting yourself as an educated consumer, I think that just even having the right mindset walking in the door and having that first meeting is super important. And to sort of drive that home, I think a woman can go into her first OB appointment to her provider and be like, I'm glad to meet you. I understand, you know, the size of your practice. I may not see you again, but it's very, very important for me to be involved in decisions that are made about my pregnancy.
Piggyback on some of that. I think it's so important, some of those things that were just said. I think that there's so much of a team approach in medicine these days that I always emphasize to my patients. You know, I work with a team. I have 6 partners in my group, and you might not see me every single time. If there's a specific question you have, I have mid-level providers and nurse practitioners that can help you and can always contact me. I do think that a lot of patients who come don't know that certain doctors only deliver at certain hospitals. And that's a really, really important place to start. And it's a good thing to know to even begin. And the other thing is knowing what is important to you and what you need to have and understand what you need to have your own needs met with the relationship before you even walk in the door. Because some patients need a more supportive relationship. Some patients just want someone to tell them what to do. Whatever works for you is fine. You just have to understand that about yourself so that you can make that right match. And when you meet the person and you understand, you know, this person's in a large group or that person's a solo practitioner, which there are fewer and fewer these days, then you don't get blindsided later when you're 30 weeks along saying, oh, that you're not going to deliver my baby. Why didn't I know that? Take it upon yourself to know that a little bit, and you'll really be helped along the way.
Heather, what are you thinking?
So I think that you can win over a relationship and you can start a relationship off really strongly in the first 30 seconds that you enter the room as a provider. Never walk in the room and stand. Always find a seat. Always just have that active listening. I am here for you right now. I can't tell you how many times I have seen people who just walk in the room and they're standing there with their arms crossed 20 feet away from the patient. And that doesn't convey anything like I'm interested in you. And the simple act, if I walk in the room, it's a new patient to me and they're already sitting on the table for a prenatal visit, I'll be like, come sit in this chair next to me. Let's hang out for a little bit. And it's just this automatic way of saying to somebody, I am not rushing out the door right now for your appointment. And it's simple body language. I think one of the things that makes where I love where I work is we are not a factory. We max out at 22, 24 patients a day. I could make a lot more money if I saw 40, but that wouldn't be fun for me. And so I think that's a great question for people to ask. I just thought of it now, but asking a new group, how many patients did the average provider see every day? Because if you think you're going to get a really great relationship with somebody who's seeing 40 to 50 people a day, I can't imagine that's possible. By us deciding to make less money to provide greater quality, it allows for me to spend the time that patients need, and that alone improves the quality of the visit. So I think that's a quick, easy question to ask before you join a new practice.
Yeah, that's a great question. And I didn't even realize that about your practice, Heather, because I know I've heard from other doctors that many of them can't even make ends meet if they're not seeing 40 to 50 patients a day. And that's not their fault. That's the fault of, the medical system. So I'm glad that you're able to do that. And it's really, really, I think it is a very, very clear signal, right, of where your values lie, if you have that option to do that. If your doctor is choosing better care over, earning more money to feed their family, like that's huge. I mean, that really speaks volumes. Dr. Rad, did you have anything you wanted to add?
Yeah, I would encourage everyone to feel comfortable at the first visit. I don't know, a lot of our patients basically interview us at the first visit. They come with a set of questions. They ask what the practice, what my practice is, how many times they'll see me, how do they get in touch with us, how many ultrasounds we're going to do, how much testing we're going to do, all the way to questions about delivery and inducing and C-section. I mean, I thought that's normal, I guess, not to come in with, I get it's interview, and oftentimes we even do like a meet and greet with some patients before they establish care. And we even have with a lot of the lost moms, we have patients interviewing us before they even get pregnant. And so they'll ask us what our monitoring would be, and we actually come up with a plan. We do like a pre-pregnancy consultation. We can come up with a plan for when they become pregnant, which might just be a few months away. And so, when they come in, we already have a plan for their whole pregnancy laid out. So I would say you don't even have to wait until your first visit. You can start looking now at your different providers and and asking for a pre-pregnancy consult even. And I think throughout the day, I was also hearing that, not everyone is referred to maternal fetal medicine. I think it's important that everyone have their OBGYN and their maternal fetal medicine specialist, or in some cases, the maternal fetal medicine specialist also does deliveries. Just sounds like some of us do. I do that. But I also just do high risk and also do deliveries, but have both options. But all patients should have both kinds of doctors, and you should ask that, because it's in our community, some of the OBs they do their own ultrasounds. They might never send you to a high risk doctor, actually, which I think is quite bizarre, but even happens here in a big city like LA. So I think someone earlier in one of the talks, they were saying to seek out, all the specialists in your area and have those contacts available. And so I would encourage you to even do it before you become pregnant. If not, as soon as you become pregnant, you don't feel, it's okay it is totally okay to interview your doctor or find that practice that will follow your wishes.
That's great advice. And I've never really heard anyone say that before, Dr. Rad, that even if you're a low risk patient, quote unquote low risk, because I was, of course, before my loss, that it's good to have an MFM on hand, because you never know when your pregnancy might become high risk. And And I remember like my OB actually sent me to an MFM for like my 13-week scan, you know, when they do some of the testing and stuff. And at the time I thought that was really odd, but you know, now in retrospect, now I know what I know. I mean, I established a wonderful relationship with that MFM, and she later became, you know, one of my main providers in my subsequent pregnancies, and I love her. So I think that's really great advice, and again, something not a lot of people might not necessarily hear. So one thing I'm thinking is I listen to you guys talk, and I love the advice that you're giving, but I also feel that it's very much, I think, of the kind of patient that comes into a doctor's office with the mindset you're describing, that, you know, I'm the customer, and I'm going to interview and find the provider who's going to give me the service that I want and deserve. I think that's very much a privileged mindset. Would you agree? Like, I don't think probably the average person is taking that perspective. So, but why do you think that is? I mean, can any patient do this? Do you have to be privileged in terms of your socioeconomic background in order to do this? Or can anybody treat their doctor this way? They just need to have the confidence and know that they deserve it.
We used to have a lot of difficulty at the hospital where I practiced seeing patients like Dr. Rad described, who wanted an MFM consult, wanted to talk to an MFM, and our office wouldn't be able to schedule patients unless they had a high-risk indication and unless the primary care provider had sent over a requisition with a high-risk indication. So insurance wouldn't cover it. So sometimes there are going to be situations, I think, for a vast majority of patients that don't have the luxury of doing that. And to your point, I think that it's not easy for most women to come in under the guise of interviewing patients, especially if they're in an underprivileged community, or, you know, they have a clinic. You can't just be like, hi, I want to interview my clinic doctor. But it is possible to interview your provider before you're pregnant. To Dr. Ed's point, that's a great idea. You can go in for a well woman GYN visit. You can go in for your yearly pap smear, because most OBs are also doing GYN. So that's kind of a nice, easy, I hate to keep saying I'm tricking the system, but it is a nice, easy sort of trick for the system. And that's what I did tell a lot of women. If you want to meet a doctor, you can't really, you know, always get an insurance reimbursement for a bunch of different doctor visits, but you can go for a well woman visit. And you can go to see a GYN for symptoms of a UTI or vaginal discharge. So there's other ways to kind of get in the door. Even if you don't have the luxury of having sort of that privileged mindset, you can still get in there.
Also, if I can add to that, you can go for a preconception consultation. And if you have a high risk indication, definitely it will be covered. But even you can just see an obstetrician gynecologist for preconception counseling. And there are codes for that can be covered by most insurances, especially I know in the state of New York, Medicaid insurances would cover that. So I don't think they'll cover multiple of them. So you can't meet every obstetrician in town to decide who you like best, but you can meet your doctor and decide if that person would be right for you with that outlet also. And that's a very, very good idea, and something that you should be doing for your own health anyway. So it's not even really gaming the system. It's using the system's resources to your benefit.
I love that. So true.
I'd say that 99% of my patients come to me via family and friends. So I think I've already been interviewed. So I don't actually get much of that. So people come to me already kind of committed. I do want to put a little plug in that we can do ultrasounds, even if we're not MFM. We have it in our practice. We are very careful. I have an amazing MFM that I work closely with. The advantage, I think, of having it in an office, which it sounds like you guys do, while you see patients for routine prenatal care, but I think not hearing the heartbeat at 10, 12 weeks, and I can take my patient, literally walk over with her and immediately do an ultrasound. And unfortunately, in our community, if we call and say we can't find the heartbeat at 12 weeks, they're waiting 4 hours to the next day. So we're very careful in our practice, but I do think we drastically improve care, especially with using the UK protocol, because after somebody has an NST, even if they have a high risk for stillbirth, we do the ultrasound immediately for growth and fluid. So I do want to put a little plug in that AIM certified OBs were really very careful with our ultrasound use. And, I'm very liberal with referring to, MFMs if I don't see anything. So I just love what it provides for our care with the immediate, a mother comes in bleeding saying, okay, we're just going to do an ultrasound immediately after we listen to your baby's heartbeat. And I do think it helps, with the kind of immediacy of that care. So
that's a really, really good point, Heather. And I know also that you've been using your ultrasound in your office to do EPV, as Dr. Kliman spoke about earlier today. And that has made a difference in several cases for you recently, which we're hoping to read about in a journal soon. But you mentioned one thing I wanted to clarify for everybody listening. So you said AIM certified OB.
Yeah.
Is that what
so
people should be looking for?
I do think you should be careful with that. Yes. You don't want regular OBGYN like myself who's doing ultrasound who isn't AIM certified. So in order to do that, I had to work very closely with MFM. Countless of hundreds of hours. We do CME related to it. All of my ultrasonographers are certified in it. And so it's really saying that you have a standard of care that you have to meet versus you just turn on a machine and plop it on. So it does kind of show that, just that you want to make sure that people are not just doing it for no reason and that it's meeting all the standards of care that's expected. So you're not, it's just not a willy-nilly doing it just because thing. But as I said, I've seen so much the trauma it causes patients when I was at my previous practice where I wouldn't find the heartbeat and they'd say, we can't see the patient till tomorrow. And I found this was a really great workaround for that kind of thing when I joined my current practice.
No, that's amazing. That I love that Heather's practice is AIUM certified. For everyone out there, it's not easy to get AIUM certified. It does require a lot of CME hours and education and applications and sending images and making sure your office is following certain policies and procedures. So it's actually very difficult to get a lot of hoops you have to jump through to get certified. It's not, and then you have to recertify every so often and redo everything all over again. So it's actually very, very hard.
All right, that's awesome. So let's talk about for patients who don't have the luxury of necessarily voting with their feet, right? Like say you live in a rural area, or say, you're on Medicaid, or, your insurance is just difficult, as many of our insurance providers are. And you're kind of, your doctor is what it is what they are, you're kind of stuck with who you've got. What advice would you give to that patient, especially when it comes to things like, requesting additional care that's maybe not part of the standard of care, or, having concerns that they don't feel are being taken seriously. We hear, unfortunately, at Push from parents directly almost every day who are in that exact situation. And our team of other moms is often jumping into action to share whatever, advice and lessons that we have learned in, as you guys have been saying, trying to, work the system and get the system better said, to work for you. Because again, we feel really strongly, every parent, every baby deserves the best possible level of care. And it shouldn't depend on who your insurer is, and it shouldn't depend on where you live in the country. But unfortunately, we know that's not the reality we live in. So for people who are kind of stuck, what's the best advice that you have to help them be heard?
I think that the best way to get heard and to develop this mutual understanding relationship with your provider, especially when you can't pick who that person might be, is to kind of approach them from a place of curiosity and say, hey, I'm interested in this specific test, or I read about this. What do you think about that? Or what has been your experience? I think so many times patients or families will come and say, well, I Googled this and I know that this is the best thing, and they really aren't open to a discussion about it. And I think working with someone and creating an open dialogue, you might learn something from your doctor, just like your doctor might learn something from you. And I think that that's the best way to create this open and honest relationship that leads to the best outcomes. And your doctor might say, hey, you know what? I don't know about that, but I'll look it up and I'll get back to you. And that's much, much better than saying, absolutely not. That's not our standard of care. We don't do that here. And you can go somewhere else if you don't like it. And I think a lot of patients get that. And it's maybe because of the way that they're coming to it. Don't come from a defensive standpoint, come from a place of curiosity.
I love that. And it's so true. And again, it all comes back to building that relationship, right? One thing that I often find myself telling parents is to say to your doctor, and it's the honest truth, right? I hear what you're saying, but I don't understand why. I know you're the expert. Can you please explain to me why you think that this is the best course of action? And, what are the other options? And why do you think that those are not the right ones for me? I want to understand because I trust you. And I think that that helps, again, to kind of like bridge that gap, build a rapport and say, I'm not questioning, that you went to medical school for 8,000 years and that you know what you're doing. I'm just trying to make sure that I understand what's going on with my own care, right?
I think that's amazing advice. And I also wanted to add that I think, so much of this is about, I feel badly because some of what we're really asking women to do is kind of like sweet talk the doctors a little bit, but that really I forget the expression, you can catch a lot of bees with honey or I don't know what the expression is, but whatever it is, that's really the mindset that is extremely helpful. And there are two things. One is a little bit, I don't want to be like angry, aggressive woman, but number one, I always tell women, do not ever say, I'm sorry, I have one more question. Don't be sorry. You're growing a human. That's a huge deal. So you are entitled to ask questions. But number two, to Dr. Shetty's point, I think that the other way that you can sort of do this is to say legitimately exactly what she said. Don't say I Googled, but I read about this and I know that you and I want me to have a healthy baby. And I know that we need to work together to do that. So can we please try to make a plan that we're both comfortable with? And if your provider doesn't agree with you, or a doctor says, we don't do that in our practice, that test is too, ask why, like you said, Sam, and then say, I understand, but it would really be very reassuring to me because I've had a prior loss, because I'm concerned my baby could pass away. Express your fear. And then ask your doctor and make them recognize that they have the same fear you do. Your doctor doesn't want your baby to die, and your doctor does not want your baby to have a bad outcome. And so you have a common interest there. And so I would, especially in practices that are very, very big, that's the most important place to say it if you don't have a relationship with your provider. So I just wanted to add on to that because I think that's great advice.
That's exactly what I wanted to say. I know earlier, some providers call their patients and some will call them clients, and we're also using the word customers. But I think it should be really a partnership, and where there's like mutual respect. And also our office, we try to make it very sort of like family-like. Even the decorations and the couches and everything, we try to make it really like home and family like. So I would come from, when you're expressing your concerns, come from a place of partnership and concern and fear, not like from a defensive or sure you're advocating for yourself, but I think sometimes that might give the wrong impression, or the doctor becomes very defensive, or they start thinking like medical legally or standard of care. I think you want them to feel like they're part of your family, they're part of your pregnancy, you're a partner, they're there to protect you, and you're seeking their help, and you come from a place of concern and fear and advocacy from that sense, rather than sort of like adversarial. So I think it's very important, and that we call it maybe a partnership or family rather than, client or we're using their customers and all that stuff, because it can make some providers or doctors feel defensive. And I would just say also just be honest, like instead of saying, I'm sorry, I have one last question, or beating around the bush, just say you're scared, your baby's not moving, there's something is not right, I'm scared. And like Tracy said, that would put a lot of fear in the doctors, but they're scared too. They don't want anything bad to happen. And I think immediately would diffuse the situation. They'll start listening to you. And so I just think it should come from a place of honesty and partnership. And one other thing I thought about establishing, and it's very hard when there's multiple providers, and I'm not in that type of practice. I hadn't thought of that until now, but sometimes I think it's helpful to tell your patients about your life and your family and get to know them, if you have other children or whatever business you do or whatever. It's not that you're just coming in, checking the heartbeat and making sure everything's okay, but they kind of know you, they know your family, they know about your siblings. I don't know, you can share about your pets. And I think that also makes a big difference too, when your doctor really knows who you are rather than just another random patient.
Yeah, and I think that comes back again to what Heather was saying before about having time, right? You don't have that. You don't get that chance to chit chat with your doctor and tell them about your adorable cat or your, older son who won't get off video games when you only have 5 minutes together. So I think that, again, really excellent advice and something that to look for, right? Is your doctor able to make small talk with you, or do they have to rush in and out, right? Are there other red flags like that you would look for? Like maybe, obviously there's some obvious red flags, right? Like a doctor doesn't make you feel safe or doesn't make you feel heard. But like, are there smaller, more subtle things that you think people should look out for that might indicate that maybe this place isn't the right fit for me?
So I think one of the best parts of my practice is our very robust RN team. There are a lot of practices, and in New York State, it's a law that you can't have an LPN triage. I don't know if that, or somebody who's not an RN triage. I don't know if that's true in every state. That don't do that rule, that you could call and have a medical assistant or a secretary actually triaging you. And I think that is a huge safety concern. Again, I love my practice because our overhead is through the roof. We don't bring home as much as we could, but we have 5 full-time nurses, and every single patient, when they call with a concern, they are talking to an RN who is certified in triaging. And I think that is so important because you don't want the medical advice coming from your secretaries or your medical assistants or your LPNs. It really needs to be an RN or higher that is doing that, because you're trusting them to realize what is concerning pain and what is not concerning pain. What is, we need to bring you in immediately and what we don't. So I think that's something to really ask. Obviously, in the current state of things, finding nurses and retaining nurses is a little harder, but I think you want to make sure that they're following the standard of care for when you call with a concern, because to me, that would be a safety concern if they're not.
Also, I just want to add to that point. I think that that's really, really important. I had a lost patient that was at a reputable infertility doctor having IVF, and she knew that there had been a genetic abnormality in her baby that she lost. And she knew that she and her husband needed to have genetic testing. And she said, okay, we have the testing, we'll get it back next week. And I thought to myself, that doesn't sound right. So when I told her to call and check on the results, I said, make sure you ask for the genetic counselor. So to your point, Heather, like, know the people who are in your office, because perhaps the right person to call is not the secretary who's going to say, hey, are the genetic results back? And it's not the proper test. And in fact, ironically, in this situation, when she did speak to the genetic counselor, she learned that they hadn't actually run the right test, and they weren't actually looking for the genetic abnormality that was found in her baby that she lost. So, just knowing the right person to understand what you're calling about is key. So I think that's like really a wonderful thing. And I wish more doctors' offices had that.
Yeah, I think just making sure that they even answer the phone, period. We have a lot of, sometimes we get a lot of calls from the patients because we're their MFM and they can't find their OB. So you want to make sure that they have an emergency after hours phone line and that they answer you in a timely fashion. I think earlier you asked like what happens if you're not feeling heard, or now that we're talking about red flags. You should know your community and what resources are available. If you ever feel like you're not heard, you can always just go to the hospital. Their hospital labor and delivery or emergency room is open 24/7. There are other providers or like nurses or midwives or OBGYNs on call who can address your concerns. So if you don't feel like something's right or you're not getting heard, or you just can't find your doctor, they're in a surgery, there's an emergency, you don't need to wait for permission. The hospital is open 24 hours a day, and when you get there, you tell them your concerns and you don't leave until you feel like they're addressed. And if there's multiple hospitals in your area, then you don't have to go to the hospital if they're where your doctor. You want to go to the nearest hospital, but just know that if you're not getting answers at one hospital, you can always go to another. And I encourage my patients to always use the hospital as a resource, and to never be shy to go there if there's something is not feeling right. And then I always try to keep them there as long as possible. I get like calls every morning at like 7. Are you sending your patient home today? But I think so. Anyway, so just know that you have the hospital as a backup too.
I think that again, a lot of moms feel like we need permission to go to the hospital, and you're so right. The hospital is always open. That's what they're there for, right? And the thing is, if you have concerns, it's really the right place to be, because if you think there might seriously be something wrong with your baby, there's not much that your doctor can do at the office. You have to be at the hospital. So if you're ever concerned, don't hesitate to go. Like Dr. Rad said, don't hesitate to go to any hospital. It doesn't have to be quote unquote your hospital. I think it's required by law in the United States that you can go into any hospital, ER in the US, and whether you can pay or not, all you can have to say is, I feel like something's wrong. Something doesn't feel right to me. And they are required to give you all the tests before they send you home. And we always tell parents, when you go in, ask for most likely they'll give you an NST. We also, and that will catch if your baby's in distress at that exact moment. But sometimes with things like cord compressions or, intermittent type issues, and NST just is not going to catch it. We talked about this last night with Dr. Harvey on our Q&A from last time. NSTs, unfortunately, have not proven to be predictive. So even if your baby is great on the NST right now, if your gut is telling you that something just doesn't feel right, stay on it. Say, I want to stay on for a few hours if possible, or maybe even overnight. Ask for a biophysical profile. That's a really detailed ultrasound where they're checking several different things to make sure that your baby is acting as normally. Even better, if those two come back clear and you still just don't feel like something is right, that's a great time to ask your doctor, hey, have you ever heard about this new tool called estimated placental volume? Because there's a good chance that if your baby's acting oddly and the other tests come back normal, they could potentially have a small placenta or something else going on, which an EPV might be able to help catch. So that's just such good advice. Parents should never hesitate to go in. Yes.
So with a patient, not too long ago, she always felt like something's wrong in the baby. She couldn't feel the baby move well. And the NSTs were always fine, ultras were always fine, but she kept saying something's wrong. Anyway, the hospital wanted to call a psych consult on her. And they did. They said something's wrong with her because she keeps coming to the hospital telling us like something's wrong. Anyway, so I ended up just keeping her in the hospital almost like the rest of the pregnancy because she couldn't tell us if something's wrong. And then even if we did like testing 3 times a week, I still wasn't sure if we would catch it. And she was high risk and she had other risk factors also. And so, but I guess a red flag is if some people want to call a psych consult on you because they call you crazy or they keep saying you're anxious and try to not acknowledge that you're not, there's something wrong.
Yeah, two things to add to that. Number one, sometimes, just to point out to providers that are listening, sometimes when patients come often, that could also be a red flag that there's domestic abuse or something else going on at home. So it's super, super important as a provider to make sure, if you have that type of situation with your patient, to make sure you explore what else is going on in their life, to do a really close head to toe physical exam, to make sure there's no signs of abuse, or to make sure that patient isn't trying to tell you something else that you're just not able to pick up. And the second thing I wanted to say was just about, like, God bless you for keeping your patients and doing continuous monitoring, because I have also had to tell patients that very commonly, if a nurse is the nurses are watching the NSTs and you're on the labor floor, and if they're super busy, they're going to do intermittent monitoring, or they're monitoring. This is all antepartum, so before the baby's born. I have told women that you can volunteer to the nurse. If your baby's hard to monitor, sometimes they're like, oh, we'll just do 20 minutes on and then take you off. Volunteer to hold the monitor yourself. Find the baby's heartbeat. If it's work, too bad, because if you're a lost mom or you're a mom who's really worried, you will hold it right there for them. And so that's something that, even though, and then sometimes the nurses are so embarrassed that they'll actually, want to get more involved. Like, no, don't worry, we can handle it. But if you can't be on the monitor continuously, tell your patients to hold the monitor themselves. Because if you're in the hospital with the goal being continuous monitoring, because as you said, Sam, the idea of prolonged monitoring is to look for patterns. A 20-minute NST is 20 minutes of what that baby is doing. And so when you go in for concerns, a quick NST and a biophysical is not usually enough. And I worked at a wonderful hospital with wonderful nurses, wonderful providers. Every time I asked for prolonged monitoring, 14 people rolled their eyes. So it is a drain on the workforce. It is a drain on the nurses. It's a drain on the residents. And so, to do as much as you can to sort of help that be user friendly, it's worth doing. So.
Thank you so much. And we are, Heather, I was gonna say, we're actually at time. So Heather, give us your last words here.
I think it's actually a good last word, because I think all of that comes down to the fatalistic idea that stillbirth is not preventable. Because if everybody truly believed that we can catch that baby and it's not going to happen, then they wouldn't fight it and they would be totally happy to do it. But the idea is, well, it's meant to be. We did the best we could, and we need to get away from that and realize that we're not doing the best we can, and that we can prevent those term stillbirths a large percent of the time.
Just to piggyback on that, and I know that we're done, but maybe what we should be doing is having a little sticker that says stillbirth is preventable and putting it on every single fetal monitor on labor and delivery. Yeah, just as a reminder.
It's true. I mean, maybe that could be a good project for Push. We will create some stillbirth is preventable stickers and send them out to all the labor and delivery floors and all the providers. Again, thank you guys all so much, not only for being here for today, but for all that you do to help empower patients, to provide, that really top tier level of care, which again, we wish every parent and every baby would receive. I mean, you guys really are a model. You are what the standard should be. And I am so excited to see what you are all going to do to help revolutionize prenatal care in this country, because I know you're all working so hard to do that. And it is needed. We need you. So thank you for being our champions. I just wanted to also thank Dr. Pakmanchetti, who did have to jump off a little earlier for her to go to her baby. But she did mention that anyone should feel free to reach out to her through the Whova conference app or on Instagram at Healthy Mama Doc with any questions. All right. Thank you guys so much. And we are going to move on now to our UnitedWePush community panel. So please join us in the next session. We're going to get that started in just a moment.
Hello, everyone. My name is Allie Felker, and I am a co-lead of legislation with Push for Empowered Pregnancy. I would like to dedicate this next session to my son, Henry Justice Felker. We call him Hank, and he was stillborn on July 1st, 2020. I have with me his bear. That is his exact weight when he was born, still at just 1 day shy of being 32 weeks gestation. Tragically, stillbirth is not the only heartbreaking pregnancy outcome. Every day in this country, birthing people are dying from or suffering the trauma of preventable complications, and infants are not making it through their first year. So I'm very, very honored to have with me so many amazing advocates who will be joining us on this panel. So let's do some quick housekeeping, and then we'll get started with introductions. First, I'd like to ask that everyone please mute yourself if you are not speaking. This is a discussion though, so once we get started with our introductions, after we do our intros, please feel free to unmute at any point in time and jump into the conversation. So we'll go ahead and start with introductions. I'd like to ask, and I'll call out your names as well. We'll start with introducing yourself and your organization. What is your mission and what drives your work? So if we can have Shawnee Benton Gibson, if you can go ahead and start, we would love to hear who you are and what the work is that you do.
Greetings. Thank you so much, Allie. And I will follow your lead by acknowledging my daughter, Shimani Makiba Gibson, who passed away in 2019 due to a birth-related pulmonary embolism. For those who do not know me, my name is Shawnee Renee Benton Gibson. I am the co-founder of the ARIA Foundation, and the mission of ARIA is actually built into the name. It's an acronym that stands for the Advancement of Reproductive Innovation through Artistry and Healing. And so we're committed to educating the community. We're committed to using art and ritual as a conduit for that, and also activating healing so that we can move forward. And I believe wholeheartedly that the conversation about these losses and the ritual we engage in is action. And so I just want to make sure that I say that, and then I pass on to the next speaker.
Thank you so much, Shawnee. We will next, let's have Amari Maynard. And I apologize to anybody who I mispronounced your names.
Good afternoon, everybody. How you doing? My name is Amari Maynard. This is Kari Maynard. I am also the co-founder of the ARIA Foundation. ARIA stands for the Advancement of Reproductive Innovation through Artistry and Healing. And we are here brought through and by Shimani Gibson, my life partner, and she unfortunately passed away, like her mother said, in October 2019. And we are here to advocate and provide different innovative ways in order to spread this word of this maternal health crisis, and to create a community in which we empower each other to know our birthing options, and then also know and provide a community in which we can support each other through our birthing journeys. Thank you.
Thank you very much. Next, can we have Lanicia Russ?
Hi, everybody. And you got it right, Allie. I'm Lanicia Russ. I am the Executive Director of March for Moms, which was founded in 2017 as a nonpartisan, solution-oriented nonprofit. And our mission is to align the diverse voices of families, healthcare providers, policymakers, and partners to advocate for mothers and families' health, well-being, and equal access to care. And something that drives our work is that we want to be a part of the collective effort of all moms and birthing people being able to experience a safe, healthy delivery without fear of dying during childbirth or after.
Thank you very much. Next, let's have Emily Little.
Thank you so much. Hi, everyone. I'm Emily Little. I use she, her pronouns. I'm the executive director and founder of Nurturely. Nurturely is a nonprofit organization focused on equity in perinatal wellness and strengthening cultures of support for infants and caregivers. So our focus is really on prevention, on preventing systemic inequities. And I come to this space as a researcher, educator, and advocate, and also want to acknowledge that I do not have the lived experience of having been a survivor of stillbirth, and want to just acknowledge my respect for fellow panelists and participants here today, and the strength that you carry in being here to advocate for fellow parents. Thank you.
Thank you. I think that's such an important part. And I mean, similarly, I want to acknowledge that I don't have the lived experience of a person of color or a person of a marginalized group. And so I think recognizing that is incredibly important. And I thank you so much for starting that. Next, let's have Jill Weber-Lenz.
Hi, everyone. Thank you to everyone at Push for having me here this afternoon. Like Ali said, my name is Jill Lenz. I am a professor of law at the University of Arkansas School of Law. I'm also a stillbirth mom. My little guy, Caleb, was stillborn at 37 weeks of pregnancy, and it will be 5 years next month. And I'm still trying to figure out how to deal with that anniversary coming up. And after Caleb died, I refocused my research, and now I'm all about how laws affect stillbirth. So like tort law and medical malpractice, and like vital statistics law and reproductive rights and justice, and how those areas of law are affecting stillbirth prevention, affecting the experience of stillbirth, et cetera. Again, thanks for having me.
Thank you so much, Jill. Next, let's hear from Debbie Hain. Debbie, I have no idea how to pronounce your full name, so I'll let you go ahead and start do that.
Oh, it's okay. You would not be the first. Don't worry about it. Hi, everybody. I'm Deb Hain, BJ Bergia. I am here as Autumn's mom. I lost Autumn. It'll be 11 years ago next in 2 months. This was not where I thought I would be in my life. I founded the 2 Degrees Foundation here in New Jersey. Our goals are to improve stillbirth outcomes, improve education and awareness around stillbirth, and to hopefully be able to provide research so that we can start to address the issues that we have here in New Jersey and at a national level. I'm also, the mission of all the work that I do, though, is really just to put stillbirth on the map across the board, whether we're in New Jersey, whether we're in the US, whether we are talking globally. I think that stillbirth needs to be recognized and finally be put on the map so that we can address this tragic maternal and family health crisis. What drives the work that I do? I think that could say that, I never knew that something like this could happen to me. I think that the first time that someone hears about stillbirth should not be when it happens to them. I never want to have my children ever experience this kind of pain. So that drives me. And I have a really hard time sitting idly by why tens of thousands of babies continue to die every year in this country. So that's me in a nutshell. So I'm just here doing my thing, and so grateful to have the opportunity to be invited to be here today, and to be surrounded by so many inspirational and devoted families and professionals. Thanks.
Thank you so much, Deb. Next, let's hear from Tina Modi.
Thanks, Allie. Hi, everyone. I'm Tina Modi. I am the co-founder of the Maya's Wings Foundation. And one of the reasons why I'm here today is, well, we started the Maya's Wings Foundation because we lost Maya last year in 2021 after IVF. We went through IVF, and after 16 weeks, we lost her due to a placental abruption. And what we've learned from that process, needless to say, I was blindsided because there's just a lack of education around the IVF process, what we should be expecting. And of course, it's definitely not because there's a lack of information that's provided necessarily. It's more of the ability to get to that information. So we started the Maya's Wings Foundation really to help empower patients and families that are going through that journey with information, resources that they can get to easily and make sure that is vetted, because there's definitely a lot of information out there in the website. So we definitely want to get that information and make sure it's vetted by clinicians, et cetera. And in addition to that, the loss of Maya helped us learn, unfortunately the hard way, that there's definitely a lot of placental abnormalities in IVF pregnancies or assisted reproductive technology when it in comparison to non-IVF pregnancies. So what we really want to do is, in addition to supporting families who are going through this journey, and also supporting families who are going through infertility, is really to help advocate and support research around abnormal placentation in IVF pregnancies, and hopefully utilize that information to translate to decrease placentation abnormalities for all pregnancies. I think all of us are here today is really to want to live in a world without pregnancy loss, preventable pregnancy loss. So that's something that I hold near and dear to my heart, and joining this group today has been amazing, and really want to get the words out there around the Maya's Wings Foundation, and definitely want to help empower folks through that journey, because there's a lot of information, but want to make sure that people can get to the right information and the correct information, and to navigate through that information. Thanks for having me.
Thank you so much, Tina. And last but certainly not least, LJ, why don't you go ahead and introduce yourself?
Thank you. I'm super excited to be here. I have experience, right? Not as a stillbirth. That is not an experience I personally have, but what I can say is, I'll start with, before my introduction, is my heart goes out to everyone, because I hear this and I see this a lot in the work that I do. So I am LJ Johnson, the owner and the CEO of LJ's Powerhouse. And so what I do is essentially educate, empower, and motivate anyone with uterus, right? That they can live an amazing life despite chronic illness, right? Despite everything that's going on. My population, my own diagnosis is I was diagnosed with endometriosis, and it took me 16 years to get that diagnosis. So throughout that process and the patients that I work with, I see a lot of things that go on, a lot of disparities, obviously, as a woman of color, and getting the information that you needed. I love what Tina said. You know, sometimes it's not a lack of information, it's just being able to get a hold of those resources. So that's really what I do, is bring in functional medicine, bring in the practitioners, and really help you get to the root of the problem so that you can prevent some of these issues as you're going through a successful pregnancy.
Thank you so very much, LJ. We'll go ahead and get started with our first question, and that is, what needs to change in order to improve outcomes for BIPOC families? Whoever wants to jump into this conversation, I think it's really important to realize there was somebody who spoke, and hopefully someone can tell me who this person was, but they said after the Aftershock documentary that all people will be safe when Black people are safe in birthing places. And that has inspired me so much to really look at the racial discrepancies, and to see that when we make this place a safe place for people of color, it will become a safe place for all of us. So whoever wants to start on that question, I would love to hear your insights.
I'd love to jump in on that one. Gosh, I'm getting very emotional. I'm getting in my feelings, right? Because this is a tough one. What has to change? I would say there's so much that needs to change, but us as influencers, us as practitioners, raising awareness, right? We don't know what we don't know. There are things that I will post on Instagram and things that I will say in workshops that are common knowledge for me, right? But for someone else, they are totally oblivious, right? So the biggest thing is raising the awareness. And then I guess I'm gonna say my second thing, because I know there's gonna be lots of things that people are gonna add, lots of gems. My second thing would be is, you know, stop hiding in plain sight. So many times we are afraid, we're feeling fear, we don't want someone to know. And it's like, yes, we've been through things, right? Yes, they're painful. I'm giving myself chills just talking about it, but it's like sharing our story is what educates and empowers others. A lot of times, like I said, circling back, you don't know what you don't know, right? So unless you're sharing your story, unless you're raising awareness, I mean, there's definitely lots of things that could change on the practitioner side, you know, people actually recognizing our pain, listening to us the first time, you know, not telling us that we're crazy, all of those things. But I would say the biggest thing is, you know, sharing the awareness, and then stop hiding in plain sight, share your story, talk about it, because you just never know who needs that information, and that will actually empower them and help them advocate, so that when they do go into the appointments, when they are talking to their practitioners, they can get better information and better care.
I'll jump in, and thank you, Ali, for mentioning Aftershock. Omari and I are two of the subjects of the Aftershock documentary. Grateful that my daughter's memory is carrying on through what LJ just shared by us being willing to be vulnerable and share our stories. What I will quickly say is that knowledge is not enough. My daughter was very knowledgeable. We're a family that has been a part of the reproductive justice movement for over a decade, and she still passed away with a doula, with a midwife, eating well, exercising, researching. It still happened to her, and it was preventable. The conversations have to start way before you are navigating whether you want to become a parent or not. When I think about my granddaughter, Anari, who's 5 years old, I'm really thinking about by the time she enters into elementary school, well, she's about to go, or junior high school, that the conversations about what her body can do, what she gets to choose to do. Like, people have an aversion around starting the conversation that young, but I wish when I was younger, someone would have talked to me about what the proper names were for my vagina, my reproductive parts, instead of calling it pocketbook and sugar bowl and down there and the thing and all of the other stuff. It starts with the language. And I keep going to events where people have chosen to be present, for me to speak, Omari to speak, to talk about the documentary, to talk about the movement. And there are still people that are in the audience in those spaces that don't know about the disparities that BIPOC folks experience, not just around reproductive health, but across the board. Finally, I will say that the conversation also about structural racism, institutional racism, implicit bias. I'm beyond diversity, equity, and inclusion. When George Floyd was choked out on the streets, and we all witnessed that across the world, I'm like, now we're using language like white supremacy culture, because that's the language that is driving the outcomes that we experience. So I'll pass to one of the other panelists, and just thank you for allowing us to be here.
And I can go next and follow Shawnee. What I want to add to the conversation is I think passing federal and state legislation and policies that we know can improve outcomes for BIPOC families is important, such as extending postpartum Medicaid coverage to 1 year after giving birth. And it gives birthing people access to postpartum care and helps them remain insured when, if they're experiencing something that they know doesn't feel right, they don't have to worry about the cost of going to the doctor or going to an ER to, get checked out. And as of May 12th, there are only 13 states that have implemented a 12-month extension, and there's only another 15 states planning to implement it as well. So we have far to go with making sure that our entire country is on board with that.
I think the only additional piece that I want to add, and I really appreciate this question because it really brings to light or really opens up that dialogue about the disparity that we see and oftentimes is not talked about. And I love the fact that we get the opportunity to talk about it. I think in addition to the advocacy work that we do for the patients, for ourselves, and the additional federal policies, et cetera, I think we need to educate our clinicians. It needs to start with education. I'm a clinical pharmacist, and I can tell you, going through my own, journey of school, we don't talk about these things. And I think anti-racism, I think it's more than just implicit bias of recognizing that, but what do we do with that information? So we need to have anti-racism type of training as clinicians to be able to say, okay, I recognize that I have this implicit bias. Now, how do I overcome that so that I can treat this person in front of me and not have all of those barriers or blurriness around it?
I wanted to jump in and just add one thing. I'm the lawyer, so of course I'm going to bring up lawsuits, but all I wanted to note is there was recently a lawsuit filed. I think the woman's name was Kara Johnson, who passed away after giving birth in LA. And it's a civil rights lawsuit. It's a racial discrimination lawsuit against the hospital. And I believe it's the first one we've seen with the racial disparity in reproductive health actually filed as a civil rights lawsuit. And it will be very interesting to see how that plays out.
I just wanted to add one thing to that. Back to what Tina was saying, I am confident that if there was better listening and better communication, we would have better outcomes. I think the mere fact that families are going in with their concerns and their concerns not being taken seriously, I think we have a serious problem with the lack of communication and the lack of acknowledgement. So I think once going back to the providers and having there be able to have a safe conversation with their patients and not be scared to listen to what they have to say and what that's going to lead to. And as far as also the risks and realities of adverse outcomes, I think that there's so much around communication as a whole that we need to improve upon. Do I know what that looks like and how to do that? No, but I do know that I personally have also experienced, what it looks like when your provider doesn't listen to you and things that could happen. And so I care very much about finding a way to ensure better listening and better communication with providers and their patients.
I just wanted to emphasize what everyone on this panel is sharing, and I'm sure everyone in this group has amazing ideas about the specific policies that can and should be pushed forward. And I also just wanted to emphasize again this point that Shawnee brought up about this is a cultural change issue. This is a white supremacy culture that extends far beyond the walls of hospital systems and birth centers. It's something that starts at birth. We know that, research shows that from infancy, how babies are being raised influences how they are a part of white supremacy culture, how you are participating in systemic racism from infancy. So it's really, the responsibility of all of us, and especially those with privilege, with white privilege, on how we are raising our babies, how we are talking about racism, far beyond, before someone is getting pregnant, far beyond before someone is having to think about where they're giving birth or how they're choosing their provider. But really, this is a cultural change issue that, I love talking amongst ourselves and all the people who are passionate about this, but we should be bringing in business leaders and people who have nothing to do with the perinatal space, because really this issue of tackling systemic racism has to bring everyone in, and it has to start before and beyond the perinatal period.
Absolutely. Amari, I want to give you a chance to chat in this conversation as well, if you have any thoughts on this question.
Yeah, definitely. Thank you for that. My stance, I second everything everybody has been saying. As a father, as somebody who's lost their partner, the biggest and realest issue is that, my children's lives is just forever changed. It doesn't matter who steps up, doesn't matter who steps in, it doesn't matter how well off we become. Their lives will forever be different without their mother being with them and through their journey. One thing as we were speaking, I was really thinking of is that it's just the reality of the situation is like when my son is 2 years old now, and when he's doing something and he gets upset, like, he's calling for daddy, daddy, daddy. But then when I come, and he's mad at me, the reality is that there is nobody else. So he calls on me still. So if he's upset, it's daddy, 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 and he's trying to run and find somebody, and it comes back to me, my kids are beautiful, they're great, and it's really cute. But at the same time, it bothers me because, there is no other option for them at this point, so there's things that really drive me to do the work and meet families and create this community, because support is paramount. When you're going through certain things, and you need people to turn to. A lot of people just don't have the support and don't know where to get the support from, and it can be traumatic. It's already a traumatic situation that we've all had to deal with. But just being able to have groups like this and discussions like this, it really does allow you to kind of breathe and know that, there are other people going through the same thing, and, can provide some insight for you.
Thank you so much. And I think that really brings to light the fact that when we're talking about stillbirth, when we're talking about maternal mortality and infant loss, we're not talking we can look at the statistics and we can see the numbers, but it's so important to realize that these are real people, that your children's lives are forever changed because of a horrifying tragedy that was absolutely preventable. And I think that whenever we have these discussions, it's easy to get stuck in the numbers, and it is painful, but it's so important to look at the people. We'll go ahead and get started on our next question, which is, what advice would you give to a pregnant person who is concerned about the care that they are receiving, and especially a person of color or someone who identifies as a member of another marginalized group, such as LGBTQ+?
I'll jump in. I often say to the folks that I have the privilege to work with is you need to date those providers like you would date somebody who's a potential intimate partner. How are they speaking to you? Are they looking at you when they are engaging you? Are they answering your questions and being respectful? When I think about, I'm 53, so when I think about my journey with medical providers, I've had folks that were just so disengaged, like moving like a conveyor belt through the process of being with me. I think about my birthing experiences. I had a very traumatic birth with my second child. She had a birth defect. I was in severe pain. She was flown out to another hospital. My former husband and I had to drive to her, and nobody asked me how I was doing. I was a Black woman away from my family. I was like a poster child for all of the things that happened to me. I went through severe postpartum depression and psychoses, and nobody said, "Are you okay?" I just gave birth. I had a traumatic birth. Baby had a birth defect. They didn't check in and say, "Mom, like, how are you processing this?" And I got really, really sick. And it's by the grace, divine intervention, that I'm still here, because I had thoughts of taking my own life, taking my daughter's life, my second daughter's life. It was really bad. And so shop for your providers. And if you don't feel comfortable, even if it's an intuitive feel, they might be saying all the right things. Use all of your intelligences to determine whether this is a good fit. It's a partnership. You know your body better than the provider. If they're not listening to you and trying to talk you out of stuff, make note and ask them if they will put in your record that they said no to this test, or something that you asked them to do because you're experiencing discomfort, or you just want to know what your options are. We must take our power back with regard to our care.
Hey, this is LJ. I'll jump in. I love what you said. It's taking your power back. I tell people all the time, even as a practitioner, sometimes you got to fire your practitioner, right? And we get very comfortable. We don't want to rock the boat. I hear it a lot in my practice. It's like my mama used it, grandmama used it, and then we've all went here, our whole family. And I'm like, here's the deal. Just because that provider has been with your family 40, 50 years, they could be amazing, but if they're not listening to you and your specific needs, right? If you come in and say something and they're like, oh, just like your mother, just like your grandmother, possibly, right? But it's a unique situation, right? The other thing I love that you said is, I always tell people, have them documented in the charts, right? If you're saying something and you have questions, it's really interesting because sometimes they'll push back and be like, hey, we're not able to do that. And my biggest thing is, awesome. Thank you, Dr. Such and Such. Document that in my chart, and I'm going to leave this appointment with that in my chart, right? It's not one of those, put it in the notes next week, follow up with me, like, oh yeah, I'll leave when the notes are updated, because then it's like, oh, they don't want to document in their chart that they can't check your calcium, or that they can't do this, or that they don't want to, because then it makes them look incompetent. And so I had one doctor, do that, and he basically just came back and was like, you win. And I'm like, well, I didn't know we were in a tussle, number one. Number two, it's like, this is my life, right? You may be in here with me 10, 15 minutes. I'm a single parent. I've got to go home to children, family, business, and I'm suffering. So you really do have to hold them accountable. And then sometimes bringing someone with you, right? Because maybe you don't have the right words. Maybe you're in pain. I've been in those appointments where I was so frustrated. You could ask me my social security number and I couldn't have told you. Like, I was so upset and beside myself. But to have someone there as an advocate that can kind of have some notes, really bring in some of the facts, because I think sometimes we get very emotional. And once you get fired up, right, we can turn to that sassy Black woman. We're like, oh, honey, we're going to clean this up real quick, right? But that's not always what's going to get us the best results, right? So I love what you shared, and I just wanted to add that to that.
And to piggyback off of you, LJ, that is exactly what I was going to add to the conversation as well, is knowing that you can bring a support person there with you when you have these conversations with your provider, whether that's a family member, a doula, a peer support worker, anyone else who's a part of your care team during pregnancy. and, you know, having them present so that you can feel comfortable with expressing these concerns, and then seeing what the response is, and knowing that if the response that you receive from your provider isn't what you were looking for, then figuring out how you can continue to escalate those concerns. My sister is always my advocate when it comes to these things as a, you know, Black woman with chronic illnesses. And she is also a healthcare admin, so she knows how to escalate if we don't get the response that we want from the person that I'm seeing. And so that's always a good way to have someone present with you.
I just want to add, and I agree wholeheartedly with what all of you are saying. I think many of us preach the same message, that we need to like empower people to feel comfortable to advocate for themselves, and especially their unborn babies, because we're the ones that know our bodies the best, and we're the ones that know our babies the best. And through my experience, I have seen that, you know, we all are raised to believe that these healthcare professionals all know that what they say is the final word. And what I've learned the hard way is that's not always necessarily true. And so the message that I'm always trying to instill in people is that they need to advocate for themselves, and they have permission. It is their human right to be able to speak up for themselves. And so, and if they don't get the answer that they want, they have the power to go somewhere else to get the care that they need, that they're not locked into their provider, that they're not stuck. They can, you know, go and try to help themselves and find someone else that will listen to them. But yeah, no, we need better communication. We need people to feel more comfortable and confident that what they have to say does matter.
I can give an example of a lived experience actually that just happened after we lost our daughter Maya last year. I think I mentioned very earlier during introduction that I felt blindsided, and to that point is really that as I was going through the IVF journey, whatever my reproductive endocrinologist told me to do, I did exactly that. I didn't ask questions. I didn't do research. I didn't use my clinical brain, even though I have that clinical training. So after losing Maya, I just kind of like, you know what? You can tell me something. Let me do the research. Let me look into it, and let me ask the questions from other providers and get other opinions. And I think everyone is saying the same thing about like, get other opinions, continue to ask these questions, because if you're not getting the answer that you want, and sometimes there might not be an answer, and that's fine. It's better that a provider will tell you like, right now we don't know, rather than saying that they do know and they give you a different answer than there really isn't any research backing for that. And I think with that really is why we are pushing for like folks to ask the questions, for folks to help bring to light what we don't know, and how can we find answers to those questions through research and continue to push forward more information that, you know, healthcare has only gone so far. And in my mind, previous to losing Maya, I thought we'd come a long way. You know, IVF has been around for a while, but no, it hasn't. It's only been around for 50 years. And there's so much we don't know, just like in stillbirth, just like in pregnancy loss, and all the complications associated, not just with pregnancy, but with like health outcomes. There's so many things we don't know, but unless we ask the question, we're not going to get the answer, or even have someone to advocate for getting that answer.
Thank you so much. Jill, I actually want to push this question to you. What are some of the legal ramifications, or what's someone's legal options if they feel that they are being discriminated against in a medical setting? Obviously, I guess we're kind of waiting to see this from the Kira Johnson case, but I would love to hear any advice that you have for if someone does want to look into their legal options.
First, I have to give the caveat that I am far from an expert on discrimination law, so I cannot comment really on that lawsuit. This is y'all, this is so heartbreaking and frustrating. Of course, like the answer is to try to advocate for yourself, but it's just so darn frustrating that we should have to in the first place, right? And you know, and how many comments I've seen today about how my doctor didn't take it seriously, and look what happened. And you know, there, if the doctor didn't follow the standard of care, then there is the possibility of a tort lawsuit. Unfortunately, there's a lot of legal hiccups in the way. I guess I'll call them hiccups. A big one is a place like California has a damage cap for non-economic damages. So in the case of a stillbirth, really the only, sorry, I don't say only to minimize, obviously, but the only damages are non-economic, right? That the emotional distress that we suffer. But those are capped at $250,000. And that's a lot of money, but it's also not. And it's hard to find a lawyer for just that amount. And I understand there's a ballot petition, there's a ballot measure on California to get rid of that or to change the damage cap. So unfortunately, there's a lot of things that are discouraging lawsuits after stillbirth, but of course it's still possible. And there are some lawyers out there who are willing. I just talked to one a few weeks ago who was just irate about it was an EPV issue of measuring placenta, and the mom was 39 weeks. And I do sort of have this idealized version of tort law that this is how we make change, right? And that's how our system is also sort of set up. That's really not probably the best way to do it, but right, that's how our system is set up. And if we have not only people who are willing to advocate for themselves in medical care, but also pursue legal options, I mean, that might be what forces doctors to change. Again, I wish we had easier answers, right? I wish we had, government run healthcare. I wish we had that we could change things in an easier way. But yes, there are some laws out there that are not really helping for lawsuits, both for maternal mortality and for infant mortality and for stillbirth.
Thank you so much, Jill. So we just have about 5 minutes left, and our final question is, what needs to change in order for the medical system to be held accountable? And I really want to tailor this question to also, what are some actionable items that we can have? Obviously, we talked about advocating for ourselves, and I think that's incredibly important. And like we've all said, it's important and exhausting. But I would love to also just see brainstorm, maybe what are some things that we can take from our conversation today and say, this is what I am going to do in my own part to really create change.
I want to jump in and share, because I think about community often before I think about these systems that impact us, that we have more power than we actually recognize. And so it's one thing for me to sit and talk with Deb and Allie and Emily about how horribly I was treated by the doctor when I went to my appointment. It's a whole other story if I actually post that somewhere and the three of us speak about Dr. Smith being rude and ignoring or being disrespectful. And if enough of those get posted and enough conversation gets out there, then nobody will patronize Dr. Smith. Also, just having a report card. It was mentioned by Jill about the standard of care. I'm like, that's terminology for me is kind of sketchy, not from Jill, but just the system that says standard of care. As a Black woman, if you know and have done your homework, you know that you can't just do with me what you have done with my white counterparts, because what can happen with me and my body based on weathering and, just the impact of just these systems and just living life as a Black or brown woman or birthing person, that the toxic stress and the different things that I deal with makes my body, it just has my body wired differently. So you might check all the boxes and I'll die. So I just wanted to put that out there. This is something that we need to work on and shift.
Shani, I love that you say that. And my head automatically goes to, we need to be able to conduct more clinical trials, folks that can trust those clinical trials, right? That you're not just using that information like Henrietta Lacks and, without permission, et cetera. I think there's a culture of untrust. And how do we shift that to a culture of trust so that we can actually conduct clinical trials with the colored population? Because we know that majority of clinical trials conducted on medications and medicine with, the way that we care for patients, it's not on the colored population, right? So to your point, Shani, we can't just have the standard of care for those that are within that clinical trial, which is majority white, and be able to translate that information for the Black folks, for the Asian folks, for et cetera. It just doesn't work that way. So until we get to a point where we can pull in more information, standardize that way, I don't think that we can truly say that we treat this person this way, we're going to treat this person that same way, and we're going to end up with the same results.
I totally agree with you. And that is kind of tied into the piece of legislation that I've been working on, the Stillbirth Health Improvement and Education for Autumn Act, which is a federal piece of legislation that would provide funding to improve the data collection and the analysis and the research so that we can better begin to prevent these losses. And I think that we don't have enough information, and we don't to be able to draw in the decision makers and say, here's the proof in the pudding. We have been consistent and concise with the data that we have collected, and this is what it is showing. We just don't have that in this country. And I remain hopeful, really hopeful that, we could get this piece of legislation passed so that it's the beginning. I mean, there is so much work that needs to be done, but until we are collecting consistent and concise data from every state in the nation, we are always going to be lagging behind what is happening elsewhere. So I agree, we need that information. And then I believe we may have a better chance at getting people to actually listen to us about what needs to be done. I think information is power.
Yes, I'll following Deb, exactly what I was going to say. Having an accurate assessment of how medical and healthcare systems address maternal morbidity and mortality and infant mortality is the only way it'll be helpful to us in holding them accountable. And then on the back end, that way we can enforce programs and initiatives to turn these systems around, specifically for BIPOC communities that, are the ones being impacted.
Thank you so much. And thank you everyone for coming today, for taking the time. I know we're running a little bit late, and also just for, sharing your stories and for sharing your hearts with us. I mean, I'm so emotional right now, and I'm so full of so much optimism, as well as just so much heart. My heart is just broken at the same time. So I really appreciate all of your stories, and thank you all so much for joining this panel.
I don't even have words to express how powerful that panel was. Thank you so much for sharing your experiences and initiatives. We can do better as a society, and I think you all just gave little pieces on how we can do that and put that into practice. Hi, everyone. I'm Liz O'Donnell. I am the co-director of communications for Push Pregnancy and the founder of Aaliyah in Action. My daughter, Aaliyah Denise Briscoe, was born still on December 1st, 2020, after what I thought was a perfect pregnancy. Today, I'm honored to dedicate this next speaker to Aaliyah and all of our babies who we know should be with us right now. Our afternoon keynote is Mason's mom, or as some of you might know her, Maya Vander. In addition to being a wildly successful real estate agent and having her own Maya Vander group, Maya has also been a star on Netflix's wildly successful series, Selling Sunset. I can tell you right now, I watched Selling Sunset over and over again after Aaliyah's death, which makes this introduction incredibly meaningful to me. Maya is the mom to 3 beautiful children, Aiden, Ella, who's celebrating a birthday today, and baby Mason, who was born still on December 6th, 2021. We invite her here today to share a little bit about her story and how stillbirth advocacy and working toward ending preventable stillbirth is helping her along her grief journey. Thank you, Maya, for joining us today and for so passionately jumping into this advocacy and change maker role.
Thank you, and I'm so glad I'm here. By the way, sorry I couldn't do the push background. I tried to do it, but I don't know, I couldn't find the setting. Anyways, Mason was born still December 9th, so 3 days difference, but that's okay. Oh, it's all good, no problem. So a few days before my delivery, which was about 38 weeks, I just felt less movement. Prior to Mason, I had 2 successful deliveries on kind of the due date. Didn't even know what stillbirth means. I'm the person who always read about pregnancy, what to expect, and every week what the baby is doing and all that. And here and there you see a line, stillbirth. But the only thing that related to it is like, don't lay on your back. So I'm like, yeah, I always sleep on my side. So when I felt less movement, I didn't even know. And I feel like, honestly, like an idiot. I should have known maybe. I just went to a private ultrasound, like kind of like one of those places you can see the baby in 3D, because I felt less movement. So I did have some bad intuition, but I didn't go to the ER. I went to a private ultrasound. It was a Sunday. She checked the heartbeat. It was perfectly normal, where it should be in that stage. And the umbilical cord was not around the neck. So for me, okay, heartbeat is fine. Umbilical cord not around the neck. Perfect. It's just big. You know, I'm 2 weeks away from my due date. That's why it's moving less. That's like literally what I was thinking. Now I know, and I heard in the past, they tell you to pay attention to the movements, but it's never really clear. So I had no clue that my baby is still with perfect normal heartbeat and umbilical cord that's away from the neck, that the baby is some sort of like distress. So unfortunately, a few days later, when I went to my regular weekly checkup, they couldn't find heartbeat, and I had to deliver my son a few hours later. And that's my story. And, you know, it's a trauma. It's only been 5 months, 5.5 months, and just trying to deal with this trauma. But because of my exposure with Selling Sunset and the huge social media following, I take this platform to help other women, because I know how I was, you know, in bad shape, doing much better, obviously. But, you know, Liz, you sent me your package, and it was very, very sweet and very helpful. I've been reading a lot of books. Then I joined one of the stillbirth group moms on Facebook, and then someone mentioned push pregnancy. So then I went to the panel there, to your Facebook web page, and I saw a discussion, you know, conversation, and Kliman was there, Dr. Kliman. So that was super helpful, because actually he managed to provide me with information on what happened to my son, which in my case was a cord compression. The cord was somehow compressed, and the placenta was slightly smaller. So combination of the two probably caused a bad accident, and unfortunately I lost him. The autopsy report came, and it was perfectly fine. The baby was normal genetically, no problem. So it's very hard to accept, because, you know, he was fine, it was normal, it was nothing genetic that I'm like, oh my gosh, thank God it happened. And it was perfectly healthy baby. And unfortunately, a lot of our, you know, stillbirth stories that I've been hearing, same story. It's just like bad luck. I wish I just knew better. I wish I could, maybe I should have gone to the ER and maybe be monitored for a couple of hours versus, you know, 15-20 minutes of like quick ultrasound with a heartbeat. So that's my story, and I am thankful in a way, because of the huge exposure that I have. I had so many women messaging me and sharing their stories, and some of them, you know, share stories that it happened to them 25 years ago. So imagine, people don't talk about stillbirth like that. It's almost like a taboo to talk about it. I feel like I personally, because of my social media exposure, I open up the door to women to share and talk about stillbirth. So, you know, it's almost like a taboo subject, like nobody talks about it. So many women messaging me, and the fact that people message me that happened 25 years ago, like it's still with them. They probably didn't talk about it 20 years ago, 25 years ago, and they felt probably some sort of relief to share their story with me. And I'm honored. Like, I've been getting emails, I read every story. I try to pay attention to my private messages. It's more common than we think. I mean, they say, yes, one out of, I don't know, 200 is the number. I feel like it's maybe more. I don't know. It's like more common, because I've been getting so many messages for women that it happens to them, whether if it's early, you know, I would say week 20, week 21, or all the way to the end. And I'm very thankful that I can relate to other women. I feel like for me personally, it helps me through the process of healing. I've been reading a lot of books about stillbirth. That helps me too. So, you know, that's my advice to women who go through this. I think books are very, very helpful. An organization like Push Pregnancy, Aliyah in Action, and, you know, like I saw a couple of your sponsors. I've been doing Return to Zero, which is a group grief for us. So all these things really helped me through the process. And moving forward, I really want to get pregnant again. For me personally, getting pregnant is part of my healing process. Maybe it sounds crazy and selfish, but that's just like how I feel. So moving forward, I know I'm going to be extra paranoid. And then what do I do? If everything check all the boxes again, do I rush to get induced at 37 weeks because I don't want to risk anything? So it's a lot of questions that run into my head. What do I do moving forward? I do not want to come to a situation that I feel less movement, because God forbid, even if you feel less movement, you can't just like deliver right away. They have to prep you. So it's just all these crazy things. But I mean, one thing at a time. I want to get pregnant again. And then once I do, hopefully I do, I'll figure it out. But really my bottom line is like, I feel like most women really should pay attention to the movements and listen to their intuition. And I was in and out with a panel today because it's my daughter's birthday. But I did hear a couple of the women saying that, they should always listen to the intuition because they had something off and, they didn't feel comfortable going to maybe the doctor and so on. So I would say, go for it. If you feel there's something off, just go to the ER, to the maternity ER, and don't hesitate, because you never know. I mean, I always thought the womb is the safest place, and they tell you, oh, don't get induced, just wait, it's going to come naturally. But sometimes, doesn't work, like in my case. So I wish I would deliver Mason at 37 weeks. It would probably be fine. So that's just my my intake for this whole crazy story. I can't even believe I'm in it. And again, some of the panelists mentioned, healthy pregnancy, normal, everything, check the boxes, nothing to be concerned. I had 2 deliveries before. Thank God, by the way. I cannot even imagine how I would feel if it would be my first baby. I think it's awful. Every loss is awful, but first baby is just even worse. So now I know. And I feel like an ignorant person, we're having 2 babies before. And I'm like, wow, how can I didn't know that? How did I not know to really pay attention to movement? Not just like, oh, if the baby, 39 weeks, whatever, the baby move less. I mean, no, I should have known better. And unfortunately, I lost my baby. So yeah, moving forward, I mean, I'm going to be that paranoid person probably. And if I need to go early to get delivered, then I'm going to insist on that and hope for the best. And thank you for having me, by the way. It's been a pleasure being involved with the organization of PUSH and with you, Liz, with Aliyah in Action. I think it's so important what you're doing. It's just so important. And PUSH too, get all these amazing smart people talking about that. I think it's incredible.
It is. It is. And thank you so much for being so open and sharing your story and using your platform to elevate this need for change. So thank you, Maya, for being here. We all truly appreciate it.
And I did promise, by the way, to share the Measure the Placenta petition.
Absolutely. Well, thank you again, Maya. All right. So before we wrap up for the afternoon, I do want to take some time to announce our prize winners that we had through the day. All right. And before I announce these winners, thank you all for the engagement throughout the day, from the questions and the comments. I hope that you were able to get to know some of our amazing exhibitors and sponsors. So the winner of our photo contest who will receive an Aliyah in Action package is Kalia Fleming. Congratulations. And email info@pushpregnancy.org so that we can coordinate how to get you your prize. And our perfect attendance winner is Alyssa LeBlanc. You won an Aliyah in Action package and 10 copies of I'm Still a Big Sister that you can donate to a nonprofit or hospital of your choice. And lastly, our passport contest winner is Rochelle Evans. And so you've won a $5 Target gift card and a Push swag bag. So to all of our winners, please do not forget to email info@pushpregnancy.org so we can coordinate how best to give you your prize. Thank you all so much for joining us for the second annual PUSH Stillbirth Prevention Symposium. I hope that you were able to connect with like-minded people and learn a little more about the advancements and research in the stillbirth space. We know how close-knit this community is, and I just want to take this time on behalf of PUSH to thank all of our medical providers, experts, and panelists for sharing their knowledge and for being a part of this movement and preventing stillbirth. Our attendees, thank you for realizing that 23,000 stillbirths a year in the United States is 23,000 too many. I hope that you can take what you've learned here and share this information with your community. Stay in touch and register to attend the Big Push in October. We will be leading the first stillbirth prevention rally on the National Mall in DC. We'll also have satellite sites in other cities, and you can attend virtually from home as well. Any way that you can attend, please do, and make sure you register at pushpregnancy.org/thebigpush. If you haven't already, please visit stillbirthstories.com to show your support for the Stillbirth Health Improvement and Education, or Shine for Autumn Act. You fill out a short form. It will ask your senator to support this historical piece of legislation. And you can come back to the app and watch the sessions from today if you missed one or want to go back to one. And over the next few days, we will be emailing a video of the symposium as well. We also have last year's symposium on the YouTube page if you want to take a look at that. For our last announcement, in honor of all of our babies and the hard work the PUSH team has put into today, we invite you to join us on Clubhouse at 4 p.m. Eastern to continue the conversation, share our takeaways, relax together with your favorite beverage, and connect. Before we close the day, we want to share a very special video with you in remembrance of our children. Our babies still count, and although it is very difficult as a mom, they are the reason we are here learning and creating powerful movements of change. Once again, thank you for joining us, and remember, United We Pushed and Preventable Support.